get started here. If the committee members could take their seats, I'd appreciate it. Just want to remind everybody that we're streaming this live on our legislative website, so that we also have some legislators that will be joining us via Zoom. And when it comes question times, I'll try to make sure we give enough time to recognize those individuals. Today's hearing is, we're going to be talking about different Medicaid delivery options. And the first up is Emily Blandford. She's the program principal, health program for the National Conference of State Legislatures. Emily here? Oh,
yep, right. I'm here.
Well, welcome, Emily.
Thank you.
I'll go ahead and yield to you, and you go ahead and start your presentation.
All right, sounds good. I'll go ahead and share my screen so y'all can see my slides. All right. Everybody see my slide? Hard to tell.
I believe so. It's
perfect. Great. All right. Well, so hi all. Thanks again for inviting me to speak today. Again, my name is Emily Blandford, and I'm with NCSL's health team, and I specialize in Medicaid policy. I've been with NCSL over 3 years now, and prior to joining NCSL, I worked in Colorado's Medicaid agency for 12 years. So always happy to be here with y'all talking about Medicaid. But before I dive into the topic today, I just briefly, for those of you who might not be familiar with NCSL, I want to provide a quick overview. NCSL is the bipartisan membership organization that serves over 7,000 legislators and more than 25,000 legislative staff in all 50 states, DC, and the territories. Our services include things such as policy research, connecting people with their peers across other states, training opportunities, as well as providing a state voice in DC, where we lobby on behalf of NCSL members. And lastly, we provide a lot of meetings and convenings to help connect people in person to, again, work across states and share information with one another. And with that quick overview, let's dive into our topic for today. So just a quick overview of what I'll be talking about. We'll be talking about Medicaid managed care, which is a type of delivery system used in Medicaid programs. So we'll talk about the primary delivery system options in Medicaid, the types of Medicare managed care systems in use and their key features, as well as how states are using some of these models. So managed care and fee-for-service are the primary delivery systems used in Medicaid programs. Managed care typically includes contracting with a managed care organization, or an MCO, and reimburses those MCOs using a capitated reimbursement, meaning a flat monthly fee paid per beneficiary. Now, I do say typically because most managed care models do use this capitated model, but there are other kinds of managed care delivery systems, and we'll talk about that in just a second. Now, the main idea behind managed care, it's fairly self-explanatory. The idea is to manage care, or in other words, provide some sort of coordination to help assure beneficiaries are getting the services they need in the right settings. And so with policymakers frequently looking for ways to contain costs in the Medicaid program in particular, managed care models are thought to be one key strategy for helping to lower costs and improve access to care. Now, since managed care plans are reimbursed at flat rate per client, the idea is that these health plans might have a little more flexibility than the state to use a lump sum to help improve that client experience and access to services. And also, by making these plans at risk for the financial downsides, which I'll talk about in just a second, there's more of an incentive for plans to provide effective and efficient care. Another feature of reimbursing managed care using this flat fee is that it often can help states better predict their annual Medicaid spending each year and can help with some budgeting certainty at the state level. Now, the other primary delivery system used in Medicaid programs is what we call fee-for-service, where services are reimbursed individually as they are provided. And you'll often hear people say that fee-for-service is volume-driven. Providers get paid more based on the volume of services they provide rather than, say, higher quality. Now, services provided through fee-for-service are often not managed or coordinated in any way, but there are managed care models that use a fee-for-service reimbursement structure. So we'll talk about those in a second too. And then lastly, just most states use a blend of both of these, both managed care capitation models and the fee-for-service model, but the vast majority of Medicaid clients receive services through some sort of managed care model. So now let's talk about the specific kinds of models of managed care that states are using in their Medicaid program. So these are specifically managed care models. So the first, comprehensive risk-based managed care. This model is the predominant model of managed care. And as I said, most Medicaid beneficiaries are enrolled in some sort of comprehensive risk-based model. Now, when you hear people talking about Medicaid managed care, this is usually the type of managed care that they're referring to. And you'll hear me call this the MCO model or the comprehensive model throughout my presentation. Now, in this MCO model, states execute contracts with MCOs and they reimburse using that capitated payment. And MCOs receive this payment regardless of whether beneficiaries actually access and use services. Now, this model, it's called at risk because MCOs are at risk for any financial losses if the MCOs end up spending more on beneficiary services than the capitated payment that they received from the state. So that's what makes it at risk. Now, on the other hand, though, MCOs are permitted to retain a portion of any excess payments or profit, assuming that they spend at least a certain amount, what we call the medical loss ratio, on medical services and other activities to improve quality. Now, another type of managed care, it's used a little less than the comprehensive model, is called primary care case management or PCCM model. Now, this is the model that combines aspects of managed care programs with fee-for-service reimbursement. So this model does not use capitation payments. Now, in this model, each beneficiary is assigned a primary care provider, which is typically a primary care physician, but other types of providers can do this service as well. And then that primary care provider is paid an administrative fee to then coordinate the services for that beneficiary. And this administration fee, it's in addition to any fee-for-service payments they receive as acting as that person's personal physician. Now, as I've mentioned, most states use a combination of these kinds of models, and they don't all have all their beneficiaries enrolled in the comprehensive MCO model. And sometimes states, they carve out particular services and benefits from their models. Now, when carving out these benefits, sometimes states provide these services through an unmanaged fee-for-service kind of arrangement, but sometimes states provide these carved out benefits through a different managed care model that I'm calling limited benefit plans here. So for example, states have frequently separated physical and behavioral health services in terms of how they deliver services on the ground. And so behavioral health has often been what we call carved out of the overall managed care model. So some states have chosen to use this limited benefit plan to cover these kinds of carved out benefits. Now, the limited benefit plan, it acts much like that comprehensive model and will really operate in very similar ways. Just these plans are often used to serve specific populations and provide particular benefits. Now, another area that I wanted to mention that often gets carved out of managed care plans are long-term services and supports, which those services are largely the services provided to individuals with disabilities and older adults to help keep them in their homes and in the community rather than placing them in a nursing facility or other kind of institution. So we've seen more and more states are starting to use managed long-term services and supports models, or MLTSS. They're using these limited benefit plan kind of models to target these specific populations. So we are seeing more and more states use this. And within this particular population, often individuals with intellectual and developmental disabilities are also carved out, as in they're not included in the limited benefit plan or the comprehensive model. But we're also seeing, again, more and more states starting to add that specific population as well, using these limited kind of benefits. So now I'm going to talk about some of the key features of these delivery systems, how they kind of compare to each other, how do the providers participate, how do beneficiaries access services, and what kind of care coordination do you expect. So when it comes to provider participation, in the comprehensive risk-based MCO model, there are requirements for how many providers are included in the MCO's network. There's also things like location standards, which can include maximum distance or travel time requirements when wanting to see specialists, for example. You'll often hear this referred to as network adequacy, which gets defined at the state level and works to ensure adequate networks to serve beneficiaries, both in terms of volume of people needing to be served, as well as locations, wait times, and adequate variety of services offered. Now, the MCO contracts with providers to make up this network. Now, you'll notice at the far right of the slide for fee-for-service, any willing provider that meets qualifications is allowed to participate in the Medicaid program, assuming they've executed an agreement with the state to do so. But the MCOs aren't necessarily required to contract with all providers, but they do, again, have to ensure those adequate networks of providers when they are making up their network agreements with those providers. Now, the PCCM model is very similar to fee-for-service in that any qualified provider can largely participate. However, there may be some additional qualifications for providers. For example, the primary care provider may have to ensure that their clinic is open at certain hours, or ensure there's after-hours phone lines or nurse advice lines, and ensuring access to 24-hour emergency treatment. So kind of a conditions of participation kind of thing under that PCCM model. Now, on the left side, what does it look like to be a beneficiary accessing services in these models? In a fee-for-service model, beneficiaries can largely receive services from any qualified enrolled provider. They don't typically need referrals, and they can usually change providers at any time. Now, in a comprehensive MCO model and a limited benefit model, beneficiaries can only see those providers who are within the contracted network. And there might also be some requirements for referrals within that network for specialist services and other kinds of non-emergency care. And within a PCCM model, beneficiaries aren't necessarily limited by the contracted provider network, but they will often need their primary care provider to issue referrals to other needed services. Now, referrals may not always be required. So, for example, routine services like an annual eye exam or a dental cleaning may not require a referral. But if someone were to need services above and beyond that routine care, it will most likely need a referral from their primary care provider. So they either work through their MCO organization or the PCCM to get access to services as a beneficiary. Now, when it comes to care coordination or actually managing care, the managed care models are very similar in their approaches, all three, the comprehensive, PCCM, and limited benefit plans. So for MCOs, there are often specific requirements that every beneficiary at least receive a handbook describing their plan benefits, as well as a health assessment to determine needs. I also mentioned disease management under the MCO, but all of these models report for disease management, which means targeted services for people with multiple chronic conditions. Now, PCCM models will often include additional case management services or other kinds of assistance in finding appropriate care and services. And then lastly, again, fee-for-service largely doesn't provide that kind of structure or assistance, although there are sometimes exceptions to that. So now let's look a little bit at which models each state is using. So this map, it shows which delivery systems are in use in each state. Now, as I've mentioned, most states use managed care models in combination with some benefits provided through fee-for-service. But as you can see here, most states use that comprehensive MCO model as their primary delivery system. Now, there's a handful of states that use fee-for-service model only, although you'll see you've got Vermont and Connecticut here as a fee-for-service only, but they do have some care coordination aspects to their fee-for-service system. And then lastly, as you can see, there's a handful of states that choose to use a combination of managed care of both an MCO model and a PCCM model, with some states choosing to use only the PCCM model to manage care in their state. Now, since most states, as I said, they're using that combination of these systems, this slide gives you an idea of the proportion of clients enrolled in each type of system. So as you can see, the majority of states have more than 75% of their beneficiaries enrolled in that comprehensive MCO model. Now, these beneficiaries still may receive some carved out services via fee-for-service or a limited benefit plan, but again, most clients go through this model of care. Now, and then just on this map, there are some of the states with no MCOs. Most of them are all fee-for-service models, but some of them will have that PCCM element to manage care. So now I just want to talk about a couple quick examples of state models to just kind of show how they get used in the states. So I've got Tennessee and Colorado here. And one of the reasons I picked these two states is because they both had similar experiences with implementing a comprehensive MCO model in the 90s, but they responded very differently to their experience with that implementation. So in response to rising caseload in the 90s, both Tennessee and Colorado decided to implement comprehensive risk-based plans. However, both states encountered significant implementation issues and didn't quite deliver on the promise they were going for to improve services and drive costs down. For example, there were a lot of lawsuits, both from beneficiaries not being able to access services, as well as providers not getting paid, as well as a whole host of other issues. So both states, they really had to reevaluate their approach. And Tennessee responded to these challenges by keeping their MCO model, but really working to strengthen it. So they did a lot of work to add more accountability, primarily in using their contracting authority a lot to try and improve care and quality and provide more oversight. And Tennessee is now often looked to as a model for how to implement managed care in your state, a comprehensive MCO plan. So at this point, Tennessee is one of the very few states that actually have 100% of their Medicaid population enrolled in that comprehensive MCO model. Now it looks like Mississippi is right up there too. According to a Kaiser Family Foundation survey, it looks like Mississippi has nearly 100% enrolled in the comprehensive managed care model, but it looks like a very small portion, less than 1%, still go through fee-for-service. But now I know the Medicaid director's here, so I'll be curious to know if that's still accurate, and so, what kinds of things might still go through fee-for-service. And then I just want to talk about Colorado's model briefly. So as I mentioned, they had a very similar experience to Tennessee in the 90s, but rather than refining that same model, Colorado chose to move away from it. And initially, they moved largely to an unmanaged fee-for-service model. But at some point, they adopted the PCCM model in their state. Now, Colorado is one who uses both MCOs still in PCCM, but 90% of clients are enrolled in that PCCM model. And then there's about 10% enrolled in a comprehensive managed care plan, which largely serves two very specific regions within the state. So it's just interesting to see how Colorado kind of went the other way, whereas Tennessee decided to refine that program and just kind of what their experiences with those programs have been. And then lastly, I've just got Wyoming up here as an example of a state that's 100% fee-for-service, since there are a lot of them, and doesn't really include a lot of care coordination features within their system. Alaska is similar. And so these are just some really high-level examples of how states are using managed care. And, as far as outcomes in using these models in states, evidence is fairly limited, and what evidence exists is mixed as to whether managed care, does it really improve access and lower costs? You will see states saying that is their experience, that they have seen some efficiencies. It has certainly been shown to help with the state level budgeting predictability, but there's not a lot of evidence quite yet to show if managed care is quite that silver bullet that we're looking for. So there's still work to see just how well managed care can work in everybody's states. So that's kind of my high level overview. This last slide here is just to provide you with some links in case you want to connect with MCSL, check out our trainings or our blog. But you can also feel free to reach out directly to me anytime, and we'll be happy to take questions.
Thank you, Ms. Blanford. I have just a couple questions. Would you agree with me if I said that the focus of managed care is to manage, the health of the population, basically, such that they alter both patient and provider behavior, so the healthcare services are, I guess, utilized and consumed in a more efficient manner?
Yes, I would absolutely agree with that. I think we largely focus on, helping change beneficiary behavior, but yes, managed care can also help improve the provider experience, better coordination across providers. And so, yes, I would agree with that statement.
Right. And early on in one of your slides, you talk about, mention examples of MCOs losing money.
Oh, I'll say it's the at-risk conversation. Yeah.
I think it was on page 5. I think one of the criticisms of MCOs and is that I don't know of any of them that actually have lost money. I think the criticism comes from the amount of profit that they seem to take from the states. Could you comment on that for us?
I don't know as much on the specifics in terms of examples where plans have lost money. I do think we largely see plans making money. I do think, though, Iowa fairly recently transitioned their whole state to managed care plans, and they started with 3 plans, and now they're down to 2. And I think at least maybe one of those plans did experience actual losses, like maybe their capitation rates just weren't high enough, but I'm not sure about those details. But I'd be happy to see if there's examples of managed care plans actually losing money and what that looks like. I'd be happy to follow up if that would be helpful.
Capitation is basically a risk-based model. How in all these states across the country, we have 3 managed care companies here in Mississippi. How important is it for the managed care companies to have a broad enough patient base so that they can actually provide these services in an efficient manner?
So that's an excellent question, but I don't know if I'm quite the right person to answer that. That one might be better for some presenters later on in the agenda. I assume it's a factor, but I can't really speak to how much of one or what kind of impacts that really has at the MCO level.
All right, thank you. Do any committee members have questions? Senator Blackman.
Thank you, Mr. Chairman. In your role as program principal, health program, National Conference of State Legislatures, have you gathered information from the state regarding what has been the best patient outcome for the use of the 3 manners in which delivery systems that you just finished testifying to?
Yes, thank you. That's an excellent question. And I had that same question myself as I was putting this presentation together. So I'm not sure. We don't collect that data. We don't have it handy. But I'd be curious to see if that data is also out there. Like, is there a difference in a client experience among those 3 different models? And again, I'd be happy to look into that and follow up with you. For example, I think with those limited benefit plans, the idea is carving out certain populations so you can focus and target specific services to them. But is that effectively working better than the comprehensive model? I'm not sure, and I'm not sure what data is out there. But again, would be happy to follow up and see what I can find.
I would very much appreciate that.
All right, happy to do it.
Any other committee members? If not, thank you, Ms. Blanford. We appreciate you taking the time to provide us with your testimony.
Thank you all so much.
Next up, we have Beth Kidder, who is the managing principal of Health Management Associates, and she's going to be coming to us via Zoom. Ms. Kidder, are you with us? You may have to. Yeah.
Now, can you hear me?
We can hear you now. Welcome.
Thank you. Thank you, Mr. Chairman, members of the committee. It's a pleasure to be here today. I appreciate the opportunity to contribute to this important conversation about how best to deliver care in Medicaid. It's a privilege to be able to share my experiences with the Florida Medicaid program. Just by way of introduction, I spent 23 years in state government, mostly in Florida, in the Medicaid program, and worked the last 4 years as the Medicaid director. I recently have joined Health Management Associates, which is a leading independent national healthcare consulting group that focuses on publicly funded healthcare. So our roots are deep in Medicaid. We've also expanded into Medicare, military healthcare, marketplace. But again, our primary focus is Medicaid. Over the 20 plus years that I worked in Florida Medicaid, I was part of the transformation of that system from being primarily a fee-for-service system into being a comprehensive risk-based managed care program. And so today I want to go over some of what we found and what we experienced as we did that transformation and what the outcomes have been for the state. So I'll go over kind of how and why we transformed the system, what kinds of results that we've seen, how we achieved those results, and briefly touch on some of the managed care challenges and the things that we were doing to mitigate those challenges. As Ms. Blanford said, managed care is now the dominant form of delivery in the Medicaid space. And there are, she did a great job showing that. I had some statistics as well, but I agree with her. It is the dominant form and growing. So in 2020, for example, 7 states added additional managed care populations into Medicaid managed care. So this is not something where Mississippi is out there doing this on its own, and this is really the way that most care is being delivered in Medicaid these days. So to give you a little bit of history and background on Florida's journey in managed care, we started this about a decade ago, and the governor and the legislature collaborated on sweeping legislation that moved the Florida Medicaid program into comprehensive risk-based managed care. At that time, Florida's Medicaid program was a collection of disparate and not very well coordinated programs that had evolved over several decades. And we had pretty much every type of delivery system that Ms. Blunt just went over, Ms. Blanford, I'm sorry. She described comprehensive managed care. We had that in some areas of the state. We also had the limited models for dental, for behavioral health. We also had primary care case management, and we had fee-for-service. So we had a little bit of everything. But none of them were producing data or accountable measures that were showing whether they were performing better than any other model. And there was no way to assess the anecdotes that kept coming about the programs, some positive, some negative, but there was no real way to judge them. And so what we did in the state was take what we had learned from those different models, the pros and cons, and crafted them into legislation for a comprehensive program that would replace all those programs. And the result of that was a comprehensive risk-based managed care program that included almost every population in the state. That included not only your healthy children and adults, but also your aged, blind, disabled populations, your children in foster care, and elders and adults with physical disabilities who needed long-term care services. At this point, I would consider the system to be pretty mature. The state is in the 2nd contract term. It has been reprocured and is heading towards the 3rd contract term soon. And so it has had time to have some results and some lessons learned. So what I saw in terms of the benefits that we got from managed care fall into 3 major buckets. One were improvements for beneficiaries, the second for providers, and then the final for the taxpayers. The primary benefits that we saw really right out of the gate were for beneficiaries. And so the first thing was that the plans were offering a number of expanded benefits, the types of things that the state could not offer to help them have better outcomes. So those were things like eliminating co-payments for services, providing a monthly stipend for over-the-counter products and medications. In the 2nd contract term, we were able to gain a full suite of adult dental benefits, which were previously not provided, and some additional mental health and substance use treatment services. Another benefit was expanded provider networks. So as I said before, there were complaints about access to care, but no real way to measure whether access was there. With the managed care system, we were able to put standards in place for how many specialists there had to be for X number of members, where they had to be geographically, and then the same thing for primary care. And that expanded the access and made it consistent across the state. We also saw a major change in long-term care. And so because of some incentives that we put into place in the program, we were able to start to shift the managed care system away from nursing facility-based care towards community-based care, which is what is preferred by our members. Over the time that we've had the program so far, we started out with only 40% of our long-term care members being served in their own homes or in community settings, and now we have 65% of them being served in the community rather than in a nursing home. We also improved access to care and quality outcomes, and I will speak more about that shortly. In terms of some of the improvements for providers, primarily what we saw was an increase to something closer to market rates for their services, particularly for specialists. That happened very quickly, where the plans were able to pay more than the fee-for-service rates, and they used that in order to ensure that they had an adequate network to meet the standards that were in their contract. We also reinvested savings from the managed care program back into physician rate increases. And so physicians were able to earn the Medicare rate, which is considerably higher than the Medicaid fee-for-service rates, if they met certain quality standards. So currently, in the current year, the value of that is about $288 million in increased rates to physicians. And it started out with just pediatricians and OBGYNs, but over time, as the savings from the program grew, we were able to expand that to all pediatric specialists as well. So all pediatricians, pediatric specialists, and OBGYNs can earn that if they meet quality standards. And those might include things like helping to divert their members from the emergency department if they don't truly have an emergency, giving them alternatives like after-hours care or a triage line, nurse triage line. Also, ensuring that children get their recommended immunizations on time and their checkups, and that women who are pregnant are getting their prenatal care visits. Those are the types of things that can earn them that additional rate. And then last but not least, for the taxpayers, one of the advantages is to flatten the cost curve. And so what we see in managed care is not necessarily that you have a complete flattening of costs, but that it starts to get less of an increase. In Florida, the managed care rate increases annually have typically been far less than medical inflation. And I know that in Mississippi, you've had some studies that show that as well, that you've had considerable savings over the projected fee-for-service costs. In long-term care, what we saw was the move away from nursing facility care meant that we could care for a lot more people in long-term care in community-based settings at a much lower per-person cost than if they had been in a nursing facility. And then finally, and very importantly, in our state was accountability and transparency. As we moved to this system, we wanted to move to a system where we actually could explain what was happening within the program for the millions of people that we were serving. And so we began public reporting of quality metrics, complaints against the plans, enforcement actions that the state had taken against the plan, and the plan's financial performance. Again, this is all very important to ensure that the public understood and could see what was going on with the program. So next, I want to spend just a little bit of time talking about what I consider to be the most important outcome, which is improved quality and access to care. So as we moved to a more systematic system, more unified system in Florida, we turned our attention away from administering a whole myriad of programs. So we have one program that we will focus on quality. And in order to do that, we selected key metrics that were nationally recognized and had national benchmarks. And so the acronyms are long, but it's HEDIS and CAPS. HEDIS measures cover most aspects of care. So preventive services like cancer checkup, cancer screenings, checkups, immunizations, care for pregnant women, care for people with complex conditions like diabetes, high blood pressure, mental health issues, and substance use issues. And so there are dozens of HEDIS measures that look at those conditions and whether people are getting the right kind of care. And then also we wanted to make sure that our members were satisfied with the care they were getting. So we used the CAHPS, which is a consumer assessment of health plan satisfaction. And that looks at timely access to care, their satisfaction with their managed care plan, whether they have enough doctors to choose from, whether they're satisfied with those physicians, and so on. So we use these because we wanted to be able to compare ourselves to other Medicaid programs and plans across the nation. These are also measures that are used in Medicare and commercial insurance, so they're very well established and validated. So our goal was to get all of the measures, and we had about 50 of them that we were measuring. We wanted to get all of them to at least the Medicaid national average, and ultimately to get them all above the 75th percentile. At this point, we went from having, at the beginning, before we went to statewide Medicaid managed care, we had 41% of our measures at or above the national average, and now we are at 67%. New data should be coming in soon, but that was the latest that we had. So a big improvement, lots of room left to grow, but going in the right direction and making a big difference. And just to give you a sense of what that looks like for real people, one of the measures whether women who've given birth get a postpartum care visit. And we know that a lot of very serious and even life-threatening conditions can emerge after the birth. So that is a very important doctor visit. When we started, only 51% of our members were getting that postpartum visit, and now that's up to 75% of them. So a big difference for our pregnant women. Also for children, newborns, in the first 15 months of life, getting their checkup. So these are really important to ensure that kids' development is being tracked properly, you're catching issues early, educating parents along the way. And we went from 54% of our new members that are under 15-month-olds getting that to 73%, so a 19 percentage point increase. So these are real changes for people, making sure that they're getting into the care that they need. Now, one of the questions that was asked earlier was which of these models is better, and just this month, HMA published a study that looked at this exact issue. So we looked at some of these key national measures and normalized them across the populations and across the states so that it's an apples-to-apples comparison. And what we saw was that managed care outperformed fee-for-service and primary care case management in all of the different categories. Now, some of them, they were closer than others, and primary care was not as far behind. But overall, managed care was out on top on all of them. That includes preventive care, women's health care, behavioral health care, and disease management, which looks at conditions such as cardiovascular disease and diabetes. So I'm happy to share that study with the committee so you can see the in-depth results of that. So based on the significant progress that we made on these in the second contract term, we focused even further and dug in deeper on the quality metrics. We started to prioritize certain measures that we saw were driving people to be hospitalized, to be readmitted to hospitals, to go to the emergency department, and we started to really focus on those, like controlling high blood pressure, controlling diabetes and asthma. And we also began to focus on preventing those hospital events wherever possible. And so a lot of that is in good care management and making sure people are getting those checkups and those check-ins on their condition. This we saw as a win-win that would reduce costs in healthcare. It would be a better experience for the member because as much as we appreciate our hospitals and the great work that they do, if you don't need to be there, we want to try to prevent that. So how we actually achieve these outcomes, it's not something that you, I think Ms. Lanford said, it's not a silver bullet. And I agree, there is no delivery system that is a silver bullet. As a state that tried multiple delivery systems, there is no one that will solve all the problems in healthcare. You have to work at it. But within the managed care system, one of the things that we found that was really important was to have a strong contract with measurable, clear goals set for the plan, and to associate both financial penalties and incentives with those outcomes. And then once you have that strong contract in place, to run a tight ship on that to do consistent and strong oversight and enforcement of the contract standards. And what that looked like for us was that if a plan failed to turn in an accurate or timely report or data, we would take action. That might mean a financial penalty. If they were not meeting standards for having enough providers in the network or having the right geographic distribution, we immediately took action on that. Also, making sure that they were timely resolving member complaints. All of these were the types of things that we routinely looked at and took action on. And there are a lot of ways that we did that, and I could get into the details of how we changed our structures to do that. But a lot of it was trying to automate some of that oversight so that there was not a lot of manual labor involved in combing through reports every month. That helped a lot. We also centralized our complaint process. We did that day one of managed care because it helped us to see trends in complaints much sooner than if they had been dispersed as they previously had been. So not only were we ensuring that the members and the providers' issues were getting resolved timely and tracked through to completion, but we could very quickly pick up on trends. And so we did a weekly review of all complaints to see what was emerging, what needed a deeper dive in monitoring. So there's some of the techniques that we use to do good oversight. Now, in terms of the managed care model itself, I think there are some things that are inherent to managed care that make it a successful model. One is that the plans have more flexibility to do things like give members incentives for healthy behaviors, to give extra benefits that can help overcome challenges that Medicaid beneficiaries have. So, for example, one of the things that we're starting to see are plans providing doula services to help with pregnancy, delivery, and postpartum so that we can tackle some of those tough issues around poor maternal outcomes and childbirth outcomes. But there are two things that I think are really important that managed care can do that typically cannot be done in fee-for-service or where the state is trying to run the program directly itself. One is value-based contracts with providers. And this is where you bring providers in to be part of the solution, part of reaching the healthcare goals. And there can be full risk involved in that for the provider. There may just be incentives. We do see the most movement in the system when the providers have some skin in the game as well through some risk-based contracting. One of the ways that we saw, for example, there's a provider that took on risk-based contracting. They saw a tremendous reduction in this pediatric practice in reduction in emergency department visits for non-emergency purposes. And they did that by a combination of good telemedicine and good outreach to their members to help them understand how to use the system better. The other thing that I think is really important in managed care is strong case management. And that is active. That's not just a phone call here and there. That's really active hands-on case management. So some of the kinds of things that you might see in a really strong case management program would be if you had a member with schizophrenia who ended up in the hospital, it's critical that as soon as that person is discharged, it's ensured that they are on their medication, that they've got a follow-up visit with their doctor and their therapist. And a case manager needs to be on top of that, getting those appointments set up right away, making sure they follow through. The other thing that we started to see is even more active case management, where a case manager or a clinician might actually go out to that person's house with a tablet and get them hooked up right then and there to a telemedicine follow-up visit. So that's kind of active intervention that's going to take to really tackle some of the tougher conditions. Another one that we see a lot of is children with asthma. They're missing a lot of school because they're ending up in the ED late at night or into the hospital. Sometimes what that takes is a home visit and a case management assessment of the home to see what kinds of triggers there might be for that asthma. And in one of the expanded benefits that our plan started offering last time was dust covers for mattresses and pillows, because that's a significant source of irritants for asthma. So these are the kinds of things that managed care can do that is very difficult for a state or a fee-for-service program to do. One last thing I'll mention in terms of flexibility is the kinds of things that happen in the disaster situations. And so I'll point out hurricanes and COVID as two of those examples. Florida being a hurricane-prone state like Mississippi, when hurricanes come, the plans contact all of their vulnerable members. That could be people in long-term care, people on dialysis, people on ventilators, and make sure that they have proper shelter. They pre-planned this, but making sure that shelter plan is in place, that they have food and water to get them through the aftermath, and then they check back with them afterwards to make sure that they are in a safe situation, they have what they need. During the early COVID lockdown, there were many people who could not get food, and the plans were arranging for delivery of food for them because they were checking in on their members. We also had plans paying for cellular data so that members could access telemedicine during the lockdown. So these are the kinds of flexibilities that we can see with managed care that, again, very difficult to do in a fee-for-service environment. Now, that is not to say that there are not challenges to managed care. There, some of the things that have been named. There's complaints that it's just another administrative layer, that plans might be profiting too much. And then there are always concerns from providers that there is too much administration for them or not timely or accurate payment. So these are endemic to managed care in the system, and they can all be mitigated with good management. So I'll give you a couple of examples on that. One thing on the administrative layer piece of that, the key is to make sure that that administration is adding benefit, and so that plans are doing, if they're doing prior authorization, it's for good clinical reasons, not just to slow things down. But this administration also ensures that there is a network that's actually taking patients. It ensures that patients are being connected to care management, and then helping them navigate the healthcare system. In terms of profits, it is critical that states keep an eye on that. It is a really important part of the rate setting process to dig deep and make sure that at an appropriate level, there needs to be some profit, or there will not be an incentive there for plans to take on this population, but it needs to be reasonable given that this is taxpayer dollars paying for this. That absolutely can be done. In Florida, we have a cap on profits after which the plans start to cost share with the state, and so that is a mechanism with independent auditing that can be put into place to help manage that. And then finally, with the concerns on providers, there's so many different mitigation strategies. The most critical thing is that the state, the plans, and the providers all stay in close contact with each other. We arranged many meetings where we would just hash through issues with providers and plans and come up with solutions. Some of those things led to us speeding up the credentialing process, requiring plans to do it faster, and eventually, like I think Mississippi is going that direction, is going to a single centralized credentialing to reduce that administrative burden. That came out of many conversations with providers over the years. Also, having a single preferred drug list across the remaining fee-for-service and across all the managed care plans, so that if you're a prescriber or a dispenser, you know what Medicaid is covering with a single list. And then also, over time, we tightened up the timeframes for prior authorization turnarounds by the plan, again, to be responsive to the provider concerns. So there are many ways that these can be mitigated. It is important to really hear the complaints and work through them to dig down to what the root causes are and then put solutions in place. So with that, I'm a believer in the managed care system. I think it can be made to work in this environment. I think it has had tremendous benefits in my state, and I'm very proud to have been part of that transformation. So thank you, Mr. Chairman, members of the committee. I'm happy to take any questions that you have.
Thank you, Ms. Kidder. I appreciate your comments on how to mitigate the, I guess, some of the perceptions of the MCOs. But I have a question I really meant to ask Ms. Blanford this, but you also touched on it, and that was on value-based care. You mentioned that you started off with pediatrics and then you expanded to OB/GYN. How long of a process did this take for you?
Yeah, this actual incentive payment took, we started it about 2 years into the program. So it was implemented about 2 years after we started managed care. where we could calculate the savings. We started, I'm trying to think, I think the first year we did just pediatricians and OBGYNs, and each year we added specialists. So over about a 3 or 4 year period, we got to the point where we were covering all pediatrics, all pediatricians, all specialists under pediatrics, and then all OBGYNs. So the goal would be to continue expanding that to adult physicians as well over time as the savings allow.
And as you went through this, and obviously the physicians or providers who perform well receive better reimbursement. Did you lose any providers, those that were on the lower end that whose level of care was not equivalent to those up at the top?
No, I mean, they're not all receiving the incentive payment, but the plans have been able to maintain adequate networks. As I briefly touched on, we actually increased very substantially the numbers of providers that needed to be in the networks in the second round of contracting, particularly on the primary care side. We doubled the number of providers that had to be there. So the plans, might need to continue contracting with providers even if they're not earning those incentives. But it was a pretty heavy motivator for providers to get on board and really start thinking systematically about the people that they serve and say, we need to make sure that we're staying on top of whether, the kids in our practice are getting their immunizations on time, getting their checkups, and staying out of the emergency room. One other way that pediatricians could qualify was to become a patient-centered medical home, which is a nationally certified model. And again, we felt that certification really showed a commitment by those pediatricians to doing good care management within their own practice.
Thank you. Any committee members with questions? Okay, seeing none, thank you, Ms. Kidder. We appreciate you taking the time to share your testimony with us.
My pleasure. Thank you.
So our first two speakers spoke from a national perspective, and so now we're coming home. So we have Drew Snyder, our Executive Director of Medicaid. Welcome, Drew.
I do have a handout in the packet if you'd like to look at that, but I'm not going to. It's not organized around the presentation, but it will give you a high-level overview of some of the things that get addressed today. Chairman Blackwell, thank you for the opportunity to speak today. And in the pharmaceutical industry, it's not uncommon for a drug originally tested for one purpose to become an effective treatment for another purpose. And this may also be the case for managed care. A decade ago, advocates of reviving the managed care delivery model in Medicaid may have sold managed care as a way to save money for cash-strapped Medicaid programs. But over time, Medicaid managed care has become more effective in serving other purposes, a revenue benefit for the general fund and a supplemental financing vehicle for Medicaid providers. Medicaid managed care does not result in national cost savings, but Medicaid managed care is providing a financial benefit to Mississippi's general fund. Medicaid managed care has been criticized by provider trade associations, but Medicare managed care has been the vehicle used to preserve billions in supplemental funding to Mississippi hospitals. I'm going to talk to you a little bit about the framework managed care operates under, some of the benefits and pitfalls of that framework, and then touch briefly on what's ahead for the managed care program. Medicaid currently provides health coverage for 834,000 Mississippians. Since 2015, the majority of Mississippi Medicaid recipients have been enrolled in a managed care delivery system. Mississippi Medicaid administers 2 managed care programs. The largest, the Mississippi Coordinated Access Network, or Mississippi CAN, has traditionally included non-disabled children, disabled adults, low-income parent caretakers, children in foster care, and a few other smaller Medicaid populations. The Children's Health Insurance Program, or CHIP, don't call it CHIPS, includes children from families with incomes higher than Medicaid eligibility thresholds, but still under 209% of the federal poverty level. These two managed care programs comprise about 60% of Mississippi's Medicaid population. Long-term care residents, individuals dually eligible for Medicare and Medicaid, and home and community-based waiver participants have remained enrolled in a fee-for-service delivery model. And for now, individuals who have maintained continuous coverage only because of the public health emergency are also enrolled in fee-for-service. Under risk-based managed care, the state pays the managed care plan a capitation rate, a fixed dollar amount per member per month to cover a defined set of services for each person enrolled in the managed care organization. In turn, the MCO pays providers for all Medicaid services an enrollee may require, that are included in the managed care organization's contract with the state. Managed care organizations are at financial risk if spending on services and administration exceeds payments, and conversely, they are permitted to retain any portion of the payments not expended for covered services and other contractual required activities, although there are federal and contractual limits on how much can be retained. These targets are set by an actuary contracted with the state and acting in accordance with federal regulations. The capitation rate to MCOs must be actuarially sound. That term, actuarially sound, means that state Medicaid agencies have to pay Medicaid managed care organizations at a rate adequate to cover expenditures for healthcare services and related administrative expenses. The requirement for actuarial soundness was put in place to prevent cost-conscious state agencies from underfinancing managed care organizations and therefore potentially compromising access to care. So today, managed care operates in what is essentially a cost plus reimbursement model. The actuary considers historical utilization, historical cost trends, price changes, emerging experience, and other factors to come up with that fixed per member per month amount. And capitation rates are established for each population group, called the rate cell, and can be different based on region of the state or the risk of the population. From that fixed dollar amount per member per month, the target expenditures for managed care provider payouts is 87.5%. If we include the approximately $570 million in directed payments to hospitals, the medical payout percentage target to providers increases to about 90%. 3% of the total cost is set aside to cover the insurance premium tax the managed care organizations pay into the state general fund, and more on that later. 7.7% of the targets for administrative expenses to cover managed care staff salaries, IT infrastructure, and other non-claims costs, and 1.8% is for targeted profit margin. In some years, like state fiscal year 2018, the provider payouts exceed the targets and the plans end up with less. In other years, the provider payouts may be lower than the targets. The design of managed care delivery systems does present some unique challenges, and these are primarily due to federal regulations governing Medicaid and managed care. The rate setting process has its issues. First, too much emphasis is placed on the rate setting process. Managed care organization leadership has been arguing unsuccessfully for higher managed care capitation rates, and instead of accepting the rates presented by the actuary, and instead of developing or instead of what our preference would be is focusing on new ways to lower costs by keeping people healthier. We are addressing this issue by giving managed care contractors a finite period in which to sign the rates. Second, the federally mandated capitation rate setting process provides a financial disincentive for improving health and health outcomes. For example, an MCO that invests in a successful care coordination program to reduce psychiatric readmissions would actually be penalized, as reductions in utilization would lead to future reductions in per member per month payment rates. When medical costs go down, eventually the capitation rates go down, potentially making it more difficult for managed care organizations to continue to invest in interventions that enable the cost reduction in the first place. This concept, known as premium slide, is a thorny challenge. Another drawback relates to beneficiary choice. The Social Security Act requires Medicaid recipients in a managed care model to have a choice of either two managed care plans or an MCO or fee-for-service option. But regulations also lead to identical or near identical benefit packages. So in most state Medicaid programs, including ours, Medicaid beneficiaries end up with the illusion of choice, picking between managed care plans that aren't all that different. This illusion of choice saddles providers and other stakeholders with extra layers of complexity and administrative burden. And while there are issues with administrative duplication across multiple managed care organizations, there are also challenges with administrative duplication across delivery systems. Mississippi Medicaid and nearly all other state Medicaid agencies continue to operate a residual fee-for-service program for a portion of the Medicaid population. As a result, a Medicaid agency must maintain information technology infrastructure, adjudicate claims, conduct prior authorizations, enroll providers, and perform other administrative functions. And taxpayers end up paying for all of it. Mississippi's managed care design has some unique challenges. In Mississippi, state law prohibits Medicaid managed care organizations from paying in-network providers below state plan approved rates, even under value-based arrangements. Prior authorization requirements implemented after July 1, 2021 can be no more stringent than prior authorization requirements in the fee-for-service program. A few weeks from now, if a responsive health plan applies a new PA criteria to a new therapy that might be viewed as more rigorous than criteria from the division's utilization management vendor, the division and the MCOs could potentially be out of compliance with state statute, even if the MCO's approach was the more sensible one. Limitations on the ability to price through network contracting or to provide proactive medical management is leaving today's managed care as a fee-for-service lookalike with administrative cost and margin tacked on. But there are significant benefits to the managed care model. The match rate for managed care organizations is identical to the federal Medicaid assistance percentage, 77.78%. And that federal matching rate can go higher under certain circumstances. This includes the administrative expenses of managed care plans. Many Medicaid employees in the Medicaid Central Office are reimbursed at 50% by the federal government. And under state law, insurers are paying a premium tax of 3% of total premium. And under federal regulations, state Medicaid agencies are required to pay for all reasonable and attainable managed care costs, which include those state insurance premium taxes. Consequently, the division ends up paying a non-federal share of about $20 million for the premium tax, but the state gets back $90 million through the insurance premium tax. So let's say in a given year, $3 billion is paid out to the managed care plans. 3% of that $3 billion or $90 million is going to be for the insurance premium tax. DOM's paying that state portion at 22.2%. That's around $20 million, with the federal government paying the other 70. So the MCOs are paying the 90 million to the state. That's going to the general fund. The state share from the division was 20 million. The state share of managed care administration and margin is around 50. So you add up the managed care administrative costs and the state share of the insurance premium, it's about $70 million. So the state ends up netting $20 million. And this is somewhat unique to high FMAP states. You reach a break-even point around 71%, and we have modeled. There's some pretty big numbers. The MCOs can make some pretty significant profit in a single year, and the state would still come out ahead on the general fund, and not to mention the benefits from the number of jobs and those types of things. Second, and maybe the most important, is the managed care organizations are a conduit for directed payments to hospitals. And under federal regulations, the state, under limited circumstances, is allowed to direct managed care expenditures to providers. MCOs can provide a uniform dollar percentage increase to network providers that provide a particular service under the contract. They're quality-based payments. These directed payment arrangements have to get CMS approval every year, but it's allowed us to put approximately $570 million annually into payments to hospitals. I will add that hospitals pay an assessment to cover the non-federal share of MHAP payments, among other things. So the net to the hospital industry is around $445 million. But nothing that I've seen at this point has convinced me that hospitals would get that type of financial infusion through fee-for-service Medicaid, which is subject to some tighter financing principles under the CFR. A clear benefit of managed care is flexibility. If a managed care organization needs to provide short-term housing to keep a member from going back in the emergency room, it has the ability to do so. If that ingenuity happened under fee-for-service Medicaid, the division would have probably violated some regulation. Managed care organizations employ people with decades of experience. They have top flight IT teams who are able to configure complex systems to accommodate dozens of state-specific fee schedules, unique provider contracts, and other rules within very tight timeframes. They have health economists who can spot trends and deliver insights on total cost of care. As a state agency head, my biggest complaint is bureaucratic handcuffs. If the division wanted to hire a health economist, we'd have to go through a lengthy procurement process. And if it didn't get thrown out because one of the bidders had their name on a page somewhere, it would we would probably wind up with a firm who lowballed to get the work and then sent us a recent college graduate. The MCOs have the flexibility to get what they need when they need it for the right price. But it's critical with that thought leadership, that they be as aggressive in serving the state's best interest, as they are their investors. As I've said, MCO, there's good local job creation. These are relatively high-paying jobs. We would like to see the footprint expanded here in Mississippi with some higher-paying positions, not predominantly, member call center, jobs. But we also are realistic and recognize that developing an insurance, workforce takes time. Speaking of insurance, Medicaid managed care does have the follow-on benefit of encouraging some additional participation in the marketplace. And regardless of one's opinion on the ACA, the marketplace is probably going to grow. The alternatives to managed care are either unproven or proven to be problematic. For the 4 previous decades, fee-for-service was the predominant model. Individual doctors, hospitals, and providers were paid for each service they delivered for a patient. This does create an incentive for providers to order or furnish more services. And different providers who see the same patient often fail to coordinate activities, leading to duplication or fragmentation. Before managed care, providers complain about the contracted utilization management review vendor. But despite its flaws, fee-for-service has had staying power. And one of the benefits is transparency. If you want to know how much an assisted living provider was reimbursed in state fiscal year 2019, that data is readily available. It's also simple. Medicaid agencies in Alabama, Connecticut, and Oklahoma are the largest Medicaid providers that continue to use mostly fee-for-service model, although Oklahoma has been attempting to transition away to managed care. Accountable care organizations, also called ACOs, have gotten attention since the Affordable Care Act. Colorado and Massachusetts are probably the two largest ACO-heavy state Medicaid programs. ACOs have been loosely defined as a group of doctors, hospitals, and other healthcare providers who voluntarily and jointly coordinate high-quality care to their Medicaid patients. ACOs are authorized by Mississippi Code Section 4313-117H, but unlike managed care organizations, they aren't prohibited from two-sided risk-sharing arrangements, and they do have some flexibility around prior authorizations. I think ACOs have some potential, but also recognize short-term limitations. It is hard for providers to understand Medicaid, the labyrinth of Medicaid regulations, but to have to learn an entirely different model of care can be a burden. Setting accurate financial benchmarks is notoriously difficult, and there are internal bandwidth issues. ACO contracting isn't as simple as plucking a model off the internet. And ACOs also lose the benefit, the premium tax. They're supporters of the model, but experts are split on the ACO's effectiveness. The most intriguing concept out there right now is in Vermont, who appears to be seeking CMS approval of a state-run managed care option where the state assumes the risk. The lower overhead and the reduced administrative duplication is interesting, but CMS approval is questionable. CMS has been historically wary of single payer MCOs, and I think ultimately what sounds good conceptually can sometimes fall woefully short in execution. Our challenge at Medicaid with managed care is like every other challenge: how to operate within the boundaries of an imperfect patchwork of federal and state regulations that rarely work well together, with vendors who have obligations to investors that may not always align with the best interest of the state. But the challenge for managed care organizations, providers, and the division is collaborating to build a true coordinated access network. When the Medicaid managed care program was created over 10 years ago, the founders didn't call them managed care organizations. They called them coordinated care organizations. And the word coordinated means to bring different elements of a complex activity or organization into a relationship that will assure efficiency and harmony. And that's what we're trying to focus change efforts on. But that change isn't going to be solely a change by the managed care organizations. The division itself and provider groups are also going to need to approach things differently. The current contract, which was entered into in 2017, was for 3 years with 2 optional 1-year extensions that allowed the contracts to go until June 30th of 2022. In the 2021 tech bill, the legislature authorized an additional extension on the contract, which, if extended, will allow the 27 contracts to continue until June 2023. The division will be jointly procuring the Mississippi CAN and CHIP programs through the same contract for the first time. Using a single contract will cut down on administrative hassle for providers, make optimal oversight more attainable, and potentially spur competition. We assigned internal staff to develop a new coordinated care RFQ. We conducted external engagement through provider and member surveys, and we were influenced by the 2021 legislative session. I think one of the clear takeaways from this session was that lawmakers seem to support standardization and uniformity when appropriate. These proposals, technically called qualifications, will be evaluated by internal subject matter experts with extensive knowledge of managed care, quality, information technology, compliance, finance, and health services. Each submission could be a few thousand pages. We don't know how many proposals the agency will receive. The evaluation committee will have to vet the proposals to make sure they're in compliance with public procurement review board rules. I would want one other warning is, protests are common for these managed care awards. The state of Kentucky is on the cusp of starting procurement number 3. Louisiana has had to rebid. Texas has had to rebid. We are going to do everything in our power to be fair, to follow regulations, and to do this in the way that is expected of us. But we cannot guarantee that there will not be noise, because that is the business that we are in. So with that, I'm happy. I know I've probably run over my time. I'm happy to answer questions.
Thank you, Drew. You're always very thorough with your presentations, and certainly appreciate your comments. There's a statement you made earlier about premium slide. And I don't know if you were here earlier, but I asked Ms. Blanford about that. If one of the focuses of managed care is to, I think it said, alter patient and provider behavior. So healthcare services are delivered in more efficient manner. It seems like that premium slide would be contradictory to what you're talking about in your premium slide. So how do we coordinate that because the concept of managed care is one that I think, in my opinion, is sound. But if we're going to penalize them for doing what the concept is, I don't know where we go. Can you talk to that?
So it's a great question, and I think it kind of leads into and goes back to value-based care. There are a couple of ways to do it. You could have you could build out rates differently, but that's not within the existing legal frameworks. And I think if you were to, even if there was the ability to get a waiver for that type of thing, I'm not sure CMS would go along with it. So the next options are looking at how making the reimbursement process different, and probably utilizing some authority within 42 CFR 438 to give us incentive payments. So you make reimbursement more based on certain quality metrics. And I don't know the answer on the track record of success there, and to be the issue really hasn't come up yet because we haven't seen premium slide. We have seen we have seen PMPM spending drop in the last 2 years, but prior to that, 2019 probably being the pinnacle of spend. That's still being used as a historical benchmark for setting capitation rates. That's not always going to be the case. So, I think the ship has turned a little bit to some pretty good medical management. Look, the pandemic has thrown everything, out of whack, but I think some good practices have gotten put into. And by that, I don't mean just denying care and slowing things down, but fundamentally sound medical management. And we do have to, that's something that we haven't answered yet. And I think there's got to be a lot of thinking around is, how do we reward success, not penalize it.
And just one more question on, for me, on your, the administrative expense you mentioned was 7.7% thing. Does that also include corporate overhead allocation?
That's correct.
All right. I would imagine for each MCO, that percentage is going to be different based upon their proprietary.
That's right.
operation.
Yeah, it depends on cost allocation methods, how much they delegate to subcontractor. Yeah, a whole host of, factors.
All right. Thank you. I'm going to open it up to other members, and I see Senator Wiggins. Did you have a question?
Yeah, excuse me. Yes, thank you, Mr. Chairman. And thank you for having this meeting. And I want to say thanks to Drew Snyder. I thought that was a very informative presentation. So I have two questions. Drew, if I understood your testimony right, you said in general, there tends to be a $20 million return to the general fund as a result, or at least with managed care program in place?
That's correct.
Okay. So that leads me to the next question, which is, I can consistently hear comments being made, and it may be, and generally is, from our friends on the other side of the chamber about the how bad managed care is. And when I think about what the previous presenter said, and then what you said about how managed care is now the dominant Medicaid delivery model in states, and more states are going to that, why do I continue to hear policymakers continue to make the argument for fee for service? And I may be putting you on the spot, but I would appreciate your answer, because when I hear your presentation and I hear the previous presentation, what I continue to hear is that fee for service, that we ought to go back to how it was 15 years ago.
Well, your judgments and your opinions often get formed by what you hear about, and lawmakers have to juggle a lot of different things. You've got energy policy, judiciary. You hear from regardless of which chamber, you may hear from a provider that has an anecdotal issue. You're probably not hearing and don't have the time to hear about, the financing, these financing mechanisms for, providers, and the advantage of using a directed payment model versus upper payment limits. I do think managed care seems to be at its most unpopular about 3 months before the start of the legislative session when the Medicaid tech bill is open. And
Right.
Complaints, I have seen the number of complaints seem to just nosedive, coincidentally about a week after probably in about April of 2021 of this year. So I don't think it's good to make policy by anecdote. And I think, there is, we hear a lot of anecdotes, but we at Medicaid, need to make sure that our data systems and our collection of complaints, and, aggregating different things from grievances from the different managed care organizations is effective and streamlined enough that we can look at that and quickly say, okay, is this a root cause issue that's a problem with multiple providers? Is this a one-off, or is this some mutual issue about missing some piece of data that's causing a hiccup in a contracting process? So I think it's that's I know a lot goes into that, but ultimately, look, I've heard it said before, 15 years ago when we didn't have managed care, everybody, and we had fee for service, everybody wanted something different. You have managed care. There's some people that would like something different. If we were to move to something else, there would still be unhappiness because, some of that may be, reimbursement driven, but, a lot of that just has to do with the fact that, Medicaid in particular, in large part because of how regulated it is on the federal level, is pretty messy. It's overly bureaucratic. It takes too long to make changes. If we want to adjust a rate on the, back when we were allowed to do that, we would have to go get permission from CMS to draw down federal funds. So, I don't have a clear, I'm not sure if I answered your question, but I know there's a lot that goes into it.
You did. Thank you. And thank you, Mr. Chairman.
Thank you, Senator Bryan.
I have two unrelated questions. I hope you have two unrelated answers. Once upon a time when managed care was getting started, the hospitals complained, and the figure they used was 10% was going to the managed care companies and not the healthcare. And so they said, why don't you just pay us the 10% and let us manage it? And they didn't have any way to do that. But as time passed, the hospitals, some of the hospitals and others have set up a nonprofit, which they've been trying to get a contract with to handle some managed care. I've always thought that it would be interesting to see if the hospitals could pull this off. I mean, whether a nonprofit dominated by hospitals will tell one of their hospitals, no, we're not paying that for that service, it's not necessary, and on and on. But I've always been intrigued as to what would happen if they tried. So why would it not be a good idea just to see if a managed care system is workable, run by a nonprofit? Why would we not want to have them as one of the managed care providers?
Look, I think I want to be careful because there is a procurement upcoming, and I don't want to, I don't want to suggest
I won't tell anybody what you say.
But look, I will say this. I think there's been a lot of discussion about, different models, provider sponsored, something that's, something that is different, testing out different things. And I think that's, I think that's certainly a fair point. I do think where we are, I do not think that we as the Division of Medicaid are in a position to say, to put our thumb on the scale one way or another and say, it's going to be a provider sponsored plan, it's going to be one of the three, or the provider sponsored plan is not going to be one of the three. And I think the way things are structured and the way our procurement laws work, we go in with coordinated care organizations, and if they're publicly traded for profit, if they're nonprofit, if they're, traditional provider sponsor, whatever, they're going to follow, they're going to, we'll have the request for qualifications, and, it'll follow the process, and whoever takes the test the best, wins. If they're now, if there's another public policy, I think that comes from the, I think that comes from the legislative side. So, and I know there was back and forth with that in 2015, but there wasn't ultimately, a mandate put in.
Well, it just seems to me that sort of a dumbed down view of this is we've got three managed care providers and they all look alike. Why would we not have this other thing that doesn't look like the other two and just see what happens out there in the real world if they had a contract. The other question I have is about mental health. And I noticed that you said one of the things managed care did was save money for the general fund. And I'm sure you said that just to see if I would go off. But the state is in the business of providing care for the mentally ill. And I would argue that historically, when the state hospital was founded, the people behind that had the best of intentions. It was good care at the time. And I really think that given what the world was like, that Mississippi's made historically a strong effort to do right by the mentally ill, given that we're a poor state and have limited knowledge and limited ability. But as time has passed, more services are being provided outside institutions. We're being sued by the feds who want us to provide more services outside institutions. And I think it's a public policy matter. We'd like to do that. One of the features of that, though, is if we're taking care of people outside of institutions as they're defined, then the individuals can be eligible for Medicaid. And of course, it saves the state a pile of money if we're providing services to someone through Medicaid rather than through 100 cent on the dollar state funds. I'm told by some people with the regional mental health centers that when they have someone in one of their facilities which is eligible for Medicaid reimbursement, which is closer to being community-based and is in the community, that they are given a limited number of days to take care of someone in their facility. They say, in fact, the individual needs to stay there longer. And in fact, the individual does stay there longer because that's what the individual needs. But that Medicaid will only pay for a certain number of days. And I'm sure that there's similar complaints everywhere, but it seems to me that there's something to that. And it would also seem to me that the more community-based services we could provide and the more money that Medicaid could spend, the better and more appropriate services the individuals would get. It would also save the general fund money by reducing our 100 cent on the dollar state dollars expenditures, and it might help us deal with this lawsuit that we have. So why are you throwing these poor people out before they need to be thrown out?
Well, I think that's the, I think that's the question. What's the appropriate, amount of time? I recognize that they, end up staying there. My understanding is, the federal financial participation comes when services are medically necessary. So, the question becomes, are the managed care plans cutting off care abruptly that is medically necessary, in which case that does not need to happen? Or are we finding ourselves in a situation where, they are making perhaps the clinically, sound choice, but there's nowhere else, to put folks. I think mental health, there are a lot of, complicated issues from we came up we were real good at the institutional side, and the workforce was built around institutions. And, now we're making, this transition to community-based services, and we've got to have there's got to be the infrastructure, in place to have the right set of services and the right people to provide those services. So, you're not the first person that's, raised this. I do think, where this has happened, it does need to, come into us so we can have, it may merit some independent review of, or, somebody clinical on our end to look at this and say, okay, are they really sending them home, too early? In which case we need to, we need to make sure that does not continue to happen.
Well, again, sort of my dumbed down thought about this is, and you're right, one of the problems is that we don't have the infrastructure in the communities, and we need to build that. And all of that takes money, and the cheapest money we can get comes through Medicaid. And so if we can access additional Medicaid funds to provide more and better community services, it's better for the clients because they're getting better and more appropriate care. And generally speaking, there's a large number of people who would prefer to get care in the community. It's less expensive in the long run, regardless of who the payer is. And it certainly saves the state money. And it seems that somehow there's some way for Medicaid to help build up the infrastructure, which you're exactly right, doesn't exist. And it's sort of a chicken and egg thing. Thank you.
I actually forgot a question that we've got a number of folks in the audience here who are probably interested in this, but when do you anticipate sending out the RFP?
Later this year.
We got, 32 days left? All right. All right, thank you. Senator Blackman.
Thank you, Mr. Chairman. How long has managed care been in the state of Mississippi?
10 or 11 years, I believe, this iteration, and then, in the mid-90s, it was here briefly.
Okay, and prior to the managed care, that's a division of Medicaid was the one processing all of these providers.
Correct. Yeah, we do work with a contracted fiscal agent, but, it was run, the claims were adjudicated through the division. Yes.
So 10 or 11 years ago, can you provide me the number of employees that Medicaid had then? Because I see here you say you have more than 800 presently.
Medicaid, I don't know the 2011 numbers. Shortly before I got there in the June 2017 numbers, there were 974. The last I checked, there were 857. I do not, there was not at that time, as we ramped up, managed care during that 2012 to 2015 period, the overall number of employees, did not drop. Now, some of that was due to the fact that the number of eligibility workers increased, which is about 2/3 of the total number of employees that Medicaid has. The central office that deal with more of the non-eligibility operations, programmatic, pieces, probably, I would have to go back and verify, but that has, declined, steadily, over time, although I do think we are at a point where, it makes, with some of the attrition to repurpose some of those vacancies for information technology and some of the more, I would say 21st century Medicaid, type, positions, is something that we need to do. But, I think, and I'm not gonna assume, anything. One thing that before I got to the Medicaid agency, it was hard for me to see you've brought this, you brought these new companies in, shouldn't there have been a huge decrease in the number of employees? Well, you still have the fee for service piece. You've got some pretty significant oversight, responsibilities. What services, there were already a number of things, utilization management and those types of things, had been outsourced. We did see probably some pretty significant decreases in the footprint of some of the contracted vendors like the UMQIO when we transitioned to, managed care.
Can you provide me those from, what was
Happy
it,
to.
10 or 11 years ago? And you say 2/3 are eligibility, so the other 1/3, they were the ones who were processing all of the Medicaid claims prior to managed care.
Well, the central office would have, you've got, your information technology function. Then you have what's, historically it would refer to as the health services umbrella, and that's been organized by benefits. So long-term services and supports, that was not rolled into managed care, that they have the waiver, population, which is, in terms of probably spend and growth, has been one of our larger, groups over the last, 12 to 15 years. Then you have the medical services, the function, and, the outpatient, hospital programs and services, those types of things. Then you get into compliance, the audit areas, third-party recovery, and then the whole finance apparatus. The finance apparatus isn't going away. I mean, we're setting rural health clinic rates, and, those types of things continue. State plans are still being updated, and it kind of goes back to what I
Can I ask
said
you
about
this question?
that
1/3 of the people that you say are not eligibility workers, could you provide me from 10 to 11 years ago, prior to managed care, what percentage of that 1/3 was processing all of the state Medicaid claims across this, all of the state Medicaid?
The claims processing piece is from the fiscal agent. So that's a separate vendor that, that actually takes the system and does the claims adjudication. That's the fiscal agent.
Okay, so the fiscal agent is no longer,
They continue to be there. Yes.
they're still there.
Yes.
Okay,
They process claims and ingest the managed care encounters and, do all other.
so they're processing the managed care claims.
They are taking in the managed care, encounters. So the managed care companies process their own claims. They go to some central clearinghouse. They have different ones, and then they send it over in a certain format to our fiscal agent who runs it through their system. So we have and we then send that to the data warehouse. So we have a full repository of payment information across the enterprise.
So we really haven't, I guess, in terms of manpower, we've not reduced manpower as a result of I think it's what, 3 billion that the managed care.
No, I would say we've, I would say we've reduced, manpower.
And would you provide me that? Thank you so much.
Thank you, Drew. Appreciate your testimony. Next up, we have Will Simpson. He's the Executive Director. He's the Vice President of Governmental Relations and Communications with Magnolia Health Plan.
Thank you, Mr. Chairman. That is a new title for me. As of 9 days ago, I was the Vice President of Compliance at Magnolia for 3 years. Very new to this job, thrown right into this around Thanksgiving. Want to appreciate you live streaming this. It used to be that committee meetings, if something bizarre happened, it became a rumor. Now it's preserved on YouTube. So if I say anything upsetting my ninth grader. We'll see it tonight when he watches this. But I want to thank you for having us today, Magnolia Health. And I want to introduce you to Magnolia Health, or reintroduce you to Magnolia Health. Just to let you know, I'm going to start at the end of my presentation. My information, contact information is on our slide presentation. It's the last slide. You have my cell phone and my email, and that will be distributed to you. I want you to contact me if you have a question about Magnolia, about managed care or Medicaid in general. It's important to us that we be a resource to you, because we've been a proud partner with the state of Mississippi now for 10 years, which obviously predated me joining Magnolia, but we want to continue to be a strong partner with the state of Mississippi. And I mean partner, I mean work together to provide quality health care, to make sure that the state's saving money, but also that the members, the beneficiaries, receive quality care. And that's important to Magnolia. I want to just kind of give you a little overview of death, taxes, and I will not be able to work this. Let's see. There we go. So I want to give you a little bit of overview of Magnolia. We are a wholly owned subsidiary of the Centene Corporation. Centene's based out of St. Louis. We're in 33 markets. We're in all 50 states in our Medicare product. But the philosophy of Centene is we do a local approach. Centene goes into a market, they set up a local corporation, they set up local executives, they hire local people, they set up a local call center, they have local nurses. So Magnolia Health has over close to 400 Mississippi jobs here in the state. Compare that to an MDA project where they employ 40 in the Delta or wherever. We're a big employer here. We have good paying jobs. These are not entry level server jobs at a restaurant. These are call center jobs where people are making a living and providing for their families. We believe that the best care is local care. And that's important to us because we want to make sure that we're reaching out in these communities. I'm from Clarksdale. I've lived all over the state. Our executive team, our CEO, Aaron Sisk, is from Madison. I can go down the list and tell you that we are Mississippians. We've lived here, we've worked here, we went to school here, we fight over the Egg Bowl on Thanksgiving, you name it. This is not the situation where somebody swoops in, takes our money and swoops out. I live in Ridgeland. I have 2 children. It's very personal for us at Magnolia because we are what we consider to be the biggest company around that nobody really knows about because we're here, excuse me. So I want to point out that we've been in this community for 10 years. And I want to show a stat. By the way, we're located in Jackson. These are local functional areas. So it's important to know these things happen in downtown Jackson. It's not happening elsewhere. We do have corporate support. We do have corporate IT support. My email address is centene.com. But the work in the communities is done right here by our people. And a large number of it is compliance. We've worked very hard with the Division of Medicaid, communicate constantly. Medical directors or local doctors, people we've worked with. So Magnolia is an insurance company. Yes, we are a managed care company. That is one of the services that we offer. But I want to point out that we cover nearly 300,000 or 300,000 plus lives in the state of Mississippi. So 2.9, 3 million people in the state, depending on what census survey you look at. We cover 10% of the state in covered lives. We have right at 200,000 people in the Medicaid program that we cover. We have 80,000, give or take, in our Ambetter for Magnolia. That is a marketplace exchange product. And Centene acquired the WellCare Medicare product. And right now there's 32,000 covered lives. That's going to grow. Magnolia is going to grow in the state, not necessarily in the Medicaid program, but in the state as an insurer. And we're proud to be here and we're proud to be covering these members. Managed care in Mississippi, to your point, Senator Blackman, this is went live in 2011. It's just the benefits. You've heard all of this today. By the way, I have a lot of slides. I want to move through this as quickly as possible. And Senator, if you want to give me some guidance, Mr. Chairman, as to what you want to talk about the most, I can get to those quickly and we can really hone in on those issues.
Just in general, how you operate, and how you function. I know a question I'm going to ask you, out of that 7.7% admin fee, what percent of that is your corporate overhead as compared to local overhead?
I don't have that number broken down today, but I can get you that number.
All right, thank you.
And I understand the concern there. And I'll get to our state rating in just a second. You'll see our growth. Magnolia has grown from 2011 from 30,000 members to 200,000 members. We've not hit another milestone for me to add anything past December 2019. I want to talk about finance. And Mr. Snyder hit on the rate care setting process. Yes, managed care approaches Mr. Snyder and the Division of Medicaid, and we discuss rates. We absolutely discuss rates, and we are pushing for higher rates when there are higher costs. But we want you to know that the division is responsible for setting the rates. They work and they have to be approved by CMS. DOM contracts with Milliman, an actuary, the state's actuary, and Milliman actually sets a rate, a proposed rate, and then they come back to the managed care companies and we look at that rate and we agree or disagree and we discuss it. Now, those that were around when managed care started, initially what happens is the actuary looks at fee for service, estimates 10 to 20% savings and goes from there. However, we have 10 years of data now in the state. So the rates are actually set based on actual cost and they look at our spend and we set those rates. This is important because there's this perception out there that managed care kind of sets its price. That's not true. This is a capitated rate set by an actuary that has to be actuarially sound. Sometimes those rates are wrong. Sometimes there's a wrinkle in the system that causes a problem. COVID, the inpatient roll in. If you have, let's say the flu season is exceptionally rough, you may have an uptick in visits, which could upset the formula. So we review those rates and we try to come up with something that's actuarially sound that allows us to meet our expenses. Mr. Chairman, this is what is set by the actuaries. You can see that from time to time, it's the medical expense is around 90%. The administrative load is 7.4%, and then the profit margin is 1.8 to 1.9%. The actual numbers, there have been calendar years where we have been underwater. We've been -1%, -2%. We can share those numbers with you. We prefer not to put these things up on a PowerPoint, they're proprietary, but the rates sometimes don't work. So over time, it evens out, but there are times when we have to say, and people say, you can't be losing money. Yes, actually, we don't meet the profit margin. Now we're paying salaries, and if we're business people, we know that administrative costs are being met. But that's the product rating that's important. I want to point out something that I don't know, I didn't catch whether or not Mr. Snyder discussed this, but the risk corridor. The risk corridor is an important concept for the legislature to understand. It can be a little complicated, but think of it as a safety bumpers. It's a ceiling and a floor. So during the pandemic, people stopped going to the doctor, but we still received the same per member per month. And so it looked like we were going to receive a windfall. Well, the state implemented a risk corridor. As of this year, or as of 2020 for Q2, we repaid the state $35 million. It looks like for fiscal year 21, we'll repay $55 million, and 22 is in process. This is not a sinister, we received money we shouldn't have had. This is a reconciliation with the state and an opportunity to keep it on the rails where there's not a windfall profit with public dollars. You cannot forget that these are public dollars. And I know that this body understands that as well as anybody, but in this risk corridor, the Medicaid has created an opportunity to protect the state, from getting upside down. We do administer the hospital access payment program. I think the cost to Magnolia for doing this is roughly $60-something for the checking account maintenance. It's a pass through. And as Mr. Snyder said, it's a lot of money to the hospitals. So we do that every month. It's not a big deal. We do it because we need to. Cost savings, I've provided this information to the legislature before. Lots of different ways to look at this. I'll let you review that. State savings, managed care cannot take full credit for state savings, but I'd like to point out that we've been a part of that. Healthcare expenses are not getting any cheaper. They are continuing to rise. Inflation is rising in the healthcare sector, and it's going to rise all over. Yes, sir.
Sorry, I won't, let me ask a question. What do you mean, healthcare expenses continue to rise?
Just the cost of goods and services.
Does compensation continue to rise to providers?
Well, the rates were frozen this year by the legislature, and the rates are set by
Well, actually, the
Medicaid.
rates weren't frozen by the legislature. That was a determination by the department to freeze the rates.
Okay, that's
But
fine.
but that's another argument for another time. But I know insurance premiums go up continually. In my business, 18% is it's going up this next year. The reimbursement we get for providing services does not go up. So I'm always curious when people talk about healthcare expenses go up. And true, the cost of our supplies go up. Everything we touch, the equipment, everything continues to increase, but the compensation does not. So I just want to make sure that we're not talking about providers or
Billing more, making more
or
money.
billing
No.
more or getting anything, because everything's done by contract, or for the most part, contract these days.
Yes,
So
sir.
it's
I was
everything's
referring to the
static.
cost of goods and services as well as inflation, and particularly healthcare inflation. So we've seen Medicaid stay flat. Managed care's played a part of that. Now you'll see a spike in 2016. In 2015, they rolled the inpatient in. So we're starting to see a slight decrease there. And those are numbers that the division can provide you, but we are providing cost certainty to the state. And that's very, very important. Claims. So I want to talk for a moment about claims. I know that on occasion you receive complaints that claims are not being paid. Claims are being paid. And let me talk you through that a little bit. This is as of September 2021, that top bullet point. We pay roughly 4.5 million claims. That's not dollars, that's the number of claims per year. And that's Magnolia. We process clean claims very quickly, meaning it is submitted in a clean form, meaning it has all the necessary information, and it's submitted electronically. The auto adjudication rate kicks in. Auto adjudication is, it's sent electronically, it's sent through a computer system. The computer system sees everything lines up. There's not something crazy or an outlier. It has the right tax ID, the right numbers on it. It is paid. I checked on this. An auto adjudicated claim that is submitted Monday morning that is clean usually will have been paid by Thursday afternoon or Friday morning. That's money in the bank for the provider. But that is a clean claim. It's based on when it's submitted and when there's a check run. So that may vary 6, 10, 14 days, but that's an important thing to know. Now, some claims have higher scrutiny. They're higher cost. These are state dollars. I want, again, accountability. Magnolia does not want to pay a claim that doesn't need to be paid. Number one, it has to be medically necessary. That's an industry standard. We utilize management techniques to look at that, to determine those things. Second, and more importantly, and I don't know if Mr. Snyder stepped out or not, if we pay claims that aren't supposed to be claimed, not only do we have to pay them back, but we're subject to penalty. We don't like paying penalties. Nobody likes paying penalties. So we do the best we can to make sure that claims are paid timely and appropriately. This is payments for 2020. This number is actually down a little bit. I believe that's COVID pandemic related. The 2019 or 2018 were around $1 billion. So $882 million were paid out. That number is difficult to conceptualize without more context. The medical loss ratio, as you can see, the higher the amount of MLR, that means the higher percentage we paid out in medical claims. The floor is 85%. It cannot drop below that. So we're paying in the 90 percentile. The target is 90.9, as you'll recall, because you have the 7% admin and the 2% profit. So we try to get as close to 90% as possible. Network, I do not like this slide. I want to be completely candid with the committee. I submitted this slide and then I looked at it and thought there needed to be a little more information there. This is actually a slide from when we receive a completed credential from a provider that is perfect. That's how quickly it's turned around. There is time where there's a go-between between a provider and the company trying to make sure we have all the necessary information. I know credentialing has been a big issue. I I want to point out that we follow NCQA standards. We have to follow those standards. There are certain things that NCQA requires for a credentialed physician. We do the best we can to help our providers get credentialed, but it's a difficult process, and I know the legislature has addressed it, and there should be a report forthcoming to you all a few days, I'm aware of. Our network, that's just some numbers of the hospitals and the specialists who are in the network. Satisfaction survey, we just received the newest for 2020. I believe we ticked up a percentage point or two. We continually get better. Overall satisfaction with Magnolia from our members is good. We're proud of that, and we work hard to keep our members happy. Pharmacy, we pay the most current version of the preferred drug list. We don't promote certain drugs over any of the other. We follow Medicaid's reimbursement methodology. We do not reject claims for any drug billed by a Mississippi Medicaid pharmacy for the purpose of redirecting them to a CCO pharmacy. They submit the claim, we pay it. Specialty pharmacy is very expensive. And I'm not an expert, and that's a whole another topic for another day, but it is very, very important to know that these drugs are becoming very expensive, $1 million drugs. Quality, I'll run through this very, very quickly. It's very, very important. We have HEDIS measurement scores. We met or exceeded division goals for 17 of them. We're seeing improvement in our, for instance, BMI percentile, counseling for nutrition, diabetes care. We're seeing results. And that's something that we ought to have a hearing on just in and of itself and let us present on results only. Quality withhold, we do meet those. It's payment withholds until we meet quality measures. CAP surveys, this is just surveys that show ratings. That number is not very good without context. Pop health management refers to what we're doing out in the communities. Utilization management, and I want to talk to this for just a second. Utilization management is very unpopular. It is someone reviewing another person's work for medical necessity. It is an industry insurance standard that happens. We have to do it. We have to do it because if we don't do it, certain people could take advantage of the system. It is accountability. And yes, it frustrates people. And yes, there's this overarching thought out there that insurance companies withhold money because they just want to hold it as long as they can and play the float and make interest. But the bottom line is we have to watch this care. Any company you bring in, even if you didn't have managed care, you would have utilization management. Private insurers have it. It's important. Unpopular, it's a necessary evil, but it is going to happen. We do the best we can when claims are rejected to give guidance so they can be resubmitted. We want to pay these claims and get them out. Utilization management and claims appeals is expensive, and it's not a win for the managed care company. It's not a win for the provider. It's certainly not a win for Medicaid. So we do our best to pay claims. Care management is important. We look at the social determinants of health. We're in the communities. I can get to some slides that show that. Start Smart for your baby. We're out there having baby showers for mothers. We're teaching about nutrition. We're providing prenatal care, counseling. They get to see, we're identifying mothers who need prenatal care. These are great programs. You can see some numbers there with deliveries. We're decreasing premature births. We're saving money this way. It's important to us that we get out and find these mothers. And that's one of the really focuses at Magnolia. This is one of the things we do best. Cognitive heart failure program, foster care. Senator Bryan, you'll recall the last time I was here, I think you and I were sparring over the term of office for the Commissioner of Child Protection Services. Foster care is critical. We're winning that fight. We're getting there. The state has made a commitment to it. Magnolia is playing a big part in that fight. I changed that number from 6,000 to 5,300 because foster care is decreasing. We have the lion's share of foster children in our care. We provide comfort bags. We provide training for CPS workers. And I think if the CPS people were here today, they would talk to you about the value of that. I know that many of you have been involved in those issues. That's expensive, but we're there working with them. And that's that's critical to us, and that's near and dear to the Magnolia heart. Benefits beyond fee for service. This is an important slide. Doctor visits. Under fee for service, you are limited to a number of visits. Managed care, you can go to the doctor when you need to go to the doctor. You get your vision checked, you get your eyeglasses. We have NICU kits, but Weight Watchers vouchers. We do fan clubs, boys and girls. We talk about health, we talk about nutrition. Mr. Snyder referenced that we can be very nimble to meet the needs of a beneficiary. You know, the idea that someone would need a wheelchair ramp under fee for service could be a problem. Magnolia can do that quickly. We can get that done quickly. If that's what the member needs, we can do that. We can provide things and we can do it in a manner that's efficient, effective, and we can keep that member out of the emergency department. Again, just some more services we provide in the management. You see on the left, the weight management, the oncology, sickle cell, HIV, AIDS. HIV can almost be eradicated now if you have medical adherence. They've gotten it to where you can't even trace it. That's important. And it's important that we have people following up with people to make sure they take their medicine. Diabetes management. Diabetes is killing people. The sugar's killing us all. Community outreach. These are just some COVID efforts that we've made. COVID has turned everything on top of its head, as you know, and we're out in the communities. I will say in the report that I submitted to you, Mr. Chairman, we couldn't get out like we wanted to, but we made 24,000 calls. If we couldn't reach out to the members and go to their house, we burned up the telephones. Every known way to get in touch with people, we did it. And that's important that you're touching those lives. Just some more community connections and community outreach. Again, this is a new role for me and I'm excited about it. I'm glad to be here and I appreciate you allowing us to speak to it. That's my personal cell. Please don't sell it to anyone, but it's here and it's out there for you all. We want to communicate. We want to be a good partner. We want to partner with the hospitals. We want to partner with all providers, particularly with the division. We've worked very hard to lower any liquidated damages or any other adverse finding against Magnolia. The last 3 years, devoted my life to it, and we've done a good job. And so we want to continue to be a partner with the state, and we're going to bid on the RFP, and we want to be here for another 10 years.
Thank you, Will. Got just a few questions. One on your utilization management. Is it peer-to-peer or is it a nurse to a doctor?
Peer-to-peer. As my understanding, it's peer-to-peer. Now, we have at the moment 3 full-time physicians on staff at Magnolia. I need to check that, but we have physicians that are reviewing these.
And I know last year we had the managed care companies come in and present, and one of the criticisms at the time was that it's not always peer-to-peer, and I think everybody heard that, and I think they were trying to adjust their system so that it was like a gynecologist to a gynecologist. And
Mr. Chairman, I'll clarify that, but I will make sure that you may have a physician to a specialist conversation. I'm not 100% sure there, but I'll clarify that.
All right.
I'll get back to you.
And again, I know you're new to this role, but on uniform credentialing, it's supposed to be implemented no later than December 1st, which is tomorrow. Can you apprise me where you guys stand with?
I think the report said that we were to give you a status update. I don't have, they've been working, they were calls as late as yesterday on this. It's been a difficult process. I'm not sure that we're 100% there, but they will submit the report.
But yeah, the report's due on the 2nd.
Yes, sir.
And I've already received one from Molina, so I'm sure yours is on the way. I'm curious, does Magnolia work with the other 2 MCOs in with respect to just dealing with the Medicaid population? Because you guys you might have some folks in Clarksdale, you got folks here, you got them up in DeSoto, you got them on the coast. And I don't know how many people you have, but maybe in terms of coordinating care, I was just wondering if you reach out to the other folks and
I wouldn't. I'd have to, not really. We're friendly competitors. We have our own members. We work with our own members. I would not say there's, like, for instance, a Clarksdale coalition of Molina, United, and Magnolia working together. We are aware of a lot of the same issues. We do communicate. We don't collude. Let's get the right wording out. We do communicate. But I would say that we, for the most part, take care of our own members.
Any committee members, questions? All right, thank you, Will. Next on the docket.
Mr. Chairman, I had a question.
I'm sorry.
Mr. Chairman, I had a question.
Go ahead, Senator Wiggins.
Thanks, Mr. Chairman. Will, I wanted to give you the opportunity on behalf of the company to explain, because I think a lot of people may not understand. But when it happened, I got a lot of questions. And what I'm talking about is the settlement of Centene with the Attorney General of the state of Mississippi. Now, Magnolia is owned by Centene, I think you said, a wholly owned subsidiary. Now, my understanding is that the settlement only dealt with the PBMs and nothing involving Medicaid management. And so please enlighten me if that's the case, and if I'm correct on that. And because I do think it was not a good look for Centene, which has a company, obviously y'all here, but I also understand that it's a separate issue. So can you please speak on that?
Sure. So in 2018, I was contacted through the Office of the State Auditor as compliance officer with a request for information regarding spread pricing. And we cooperated with the state auditor and provided them with the information they needed through a law firm. And we sent over that information and didn't hear anything for a while. It's an accusation that the PBM or that Centene participated in a spread pricing mechanism, which was legal previous to it not being legal. I don't know, Senator Wiggins, a lot about it because it was a corporate matter dealing with the PBM. It was not a local Magnolia issue, although it took place in Mississippi with the PBM. Corporate Centene negotiated a no-fault settlement, and they reached a number agreement, and that's the information I have. I don't.
But that had nothing to do, and correct me if I'm wrong, but that had nothing to do with the Magnolia and the managed care division.
Well, from the Magnolia perspective, that's correct. Magnolia was not involved in that issue. It was a national PBM corporate issue, and the local Magnolia team was not involved in that.
Okay, and just to be clear, because you mentioned in your presentation about the drug prices or drug, I guess, formularies, y'all aren't using that, meaning Magnolia's not using
that's
that
right. No,
PBM that's at issue.
No, and in fact, Magnolia is involved in the corporate. We're looking at different PBM structures and things. That's changing, Senator Wiggins, and probably in response to the settlement. We pay the Medicaid rate. The PBM for us is simply a conduit to pay it. Again, Magnolia locally didn't have much to do with this, and the settlement was really with our corporate company.
Right, but you do, and I understand that, but you do understand when there are those out there that when that comes out, they, for lack of a better term, conflate Centene and want to make it all one. And you understand that. And I'm not saying that's right. I'm actually saying that's wrong, but you understand that that has happened.
I do understand that. I mean, it's an optics thing. But what I can represent to the committee is that the PBM was employed by our parent company. This was not a Magnolia local issue. The Mississippi claims were all submitted. We cooperated fully, and the corporate put it out there. And yes, I mean, my email says Centene, my paycheck says Centene. But at the end of the day, from a Magnolia perspective and a local perspective, we weren't involved, and the settlement was negotiated, and we're putting it behind us and moving forward.
Okay. Thank you, Will, for your presentation.
Thank you.
Thank you, Will. Next, we have Bridget Galatas, who's the Plan President and Chief Executive Officer of Molina Healthcare.
Good afternoon, and thank you, Mr. Chairman.
Good afternoon, Bridget.
I don't have any particular handouts. I just wanted to talk to you today about what Molina is doing, what our outcomes look like, and where we're going in the next year or so. We're in a different phase than I think United and Magnolia, because we just came onto the scene. We just made our 3-year anniversary for Mississippi Can and our 2-year anniversary for CHIP. So we're a little bit earlier in the life cycle and the development of our programs. And just to remind everyone, when we started at the beginning of 2018, we had, or at the end of October of 2018, we had 8,000 members. And so we've grown over this 3-year period, month by month by month. So our data and our membership and our member mix has been evolving as we've gone through the process. So, we're doing some things this year that we've just now been able to get enough data to do when we're talking about value-based reimbursement and that sort of thing. So just setting the stage there for some of the discussion a little bit later. Molina Healthcare, we are in 19 states. We do government business only. We're growing, and there's a lot of good things going on within the organization. But we want to know what's going on in Mississippi. So we have been working with our corporate teams over the last 1.5 years, really, to really engage with our teams at corporate and give them information about what's going on in Mississippi. And we've been lucky enough to really grab the attention of our leadership. So Joe Zabretzky is very versed in everything that's going on in Mississippi. He's got now he's got this interest in the Delta and what's going on there and how we can be involved and what we can do. So we'll talk about the future in just a minute. But the organization as a whole is very committed to the state. We just renewed our lease in One Jackson Place. We have 3 floors there. We have our contact center here as well. We have about 120 actual health plan employees right now to service about 111,000 CHIP and CAN members. We also have marketplace business this year, and so we have about 30,000 members there. But we've got that local focus on the members for Mississippi. So want to make sure that everybody understands it's a very Mississippi-centric view of the population. We are fully integrated with physical health and behavioral health. So our care managers handle the member completely. So if there's a behavioral health issue, they're also working on the physical health side as well, so that we can have that continuity of care and really service that member. What we've seen in our member mix since we started is we are very skewed to moms and babies. So when we started here, we made the commitment that we wanted to improve the health of that population. We wanted to improve the outcomes. So we made sure that we have every single mother involved in care management if they would like to. Now, they can always opt out, but if they want to, they are able to be involved in a care management program. So we're not just looking at high risk OB, we're looking at maternity in general. So doing that, we've gotten a really good engagement rate. Preterm, the engagement rate drops down a little bit on the postpartum side, so we're working on that now. We've got a breastfeeding program for moms. We're giving out breast pumps, and we're also working now with WIC to partner on different methods and different tools that mothers can use postpartum. So we're really excited about that. When it comes to outcomes, we have been very focused on NICU, and I think we've talked about this before, but wanted to give you an update on that. We have brought down our NICU cost over 50% since October of 2018. When you look at it on a per member per month basis, our NICU costs have gone down over 50%. So that's great. That's the cost side. But what does the care side look like? Because I think sometimes we're accused of managing cost and not managing care. But on those NICU stays, we've brought down the average length of stay by over 20%. So we're managing the cost, but we're really focusing on managing the care as well. Continue to focus on that. I get a daily census every single day of how many babies we have in the NICU. Very focused on that as well as maternal health, and have had a lot of success there. We're working on our emergency room visits now, and we are seeing some success there. We're reducing the number of ED visits, and we're seeing the cost per ED visit go up. Now, normally that wouldn't make a lot of sense, but what that says is if you've got lower number of people going in, the costs are going up, then that means people are going in for the right things. These higher cost things would be services that you would want to provide in an emergency room. So we're watching that very closely and staying connected there. We talked about the fully devoted staff. Will mentioned in his presentation some of the additional benefits that we all offer, unlimited visits to the PCP, Weight Watchers. There's just several different options that we bring to the table, and each of us have a little bit of a nuance here or there, but there's a whole list of additional benefits that we provide. Vision, hearing, transportation, all of those things, of course, are included. One of the things that we're doing this year to make us even more locally focused is we've transitioned our dental vendor to a hybrid model where the provider is fully taken care of within Molina. So if a provider needs, an authorization, or they need to just find out what's going on with their bill or anything like that, is handled by our team. So we're trying to give our dentists and our, the dental population more service and that hands-on care with them. Because I think there's been a need we've seen in terms of building that out. So we're excited about that. That went live October 1st. Everything's looking great there. So where are we going? This year, we have partnered with the Department of Health, and Dr. Joyner is here, and Rich Jones, my VP of Healthcare Services. We partnered with the Department of Health to help with the vaccine efforts. So our team has been in the field. It's our employees, our nursing staff, our physicians who are living in Mississippi. They've been doing it on their volunteer time. We've been doing vaccine clinics across the state. And in those vaccine clinics, we'll take anybody. It's not just Molina members. We will take care of if you got Blue Cross, if you've got Magnolia, if you've got United, whoever, or if you have no insurance. We will take you and get you vaccinated and make sure that we're staying in touch with you. So that's been a really big effort for us, and we've been excited about it. Our team has been excited about being able to get out and really make a difference. So the next things that we're looking at are, what are we doing in the next 12 to 18 months to continue to improve health? I know our CEO, Joe Zabretsky, had a conversation with the governor a couple of months ago, talking about some of the things that we want to do to continue to drive outcomes. And right now we're seeing access issues, particularly in the Delta. So we have a mobile solution that we will be rolling out. Our units should be ready in the first quarter of 22, that we will be able to get out in the community and actually provide care in our mobile units and get to those places where maybe somebody can't get to the doctor, they don't have transportation. There's a continuity of care, keeping them, if they have follow-up visits, all of those things, we can actually be out in mobile units servicing the population. And that's being done through our foundation. So there will be opportunity for us to work with members across the board. So not just Molina members. We know that if we want overall to make a difference, to turn the dial, to really improve outcomes, we have to look past our 111,000 members. We want to continue to grow, but we really want to be involved in the solution here. So we're focusing on those things going forward, continuing to drive outcomes and continuing to support our Mississippi-based employees and our commitment to the state.
Thank you, Bridget. I just want to clarify something. You talked about your COVID shots and you referenced it doesn't matter what kind of insurance they have. These shots are free, are they not? I mean, you're basically doing this as a community service
Yes.
outreach. Okay.
Yes.
I just want to
Yes.
make sure because it sounded like you might be billing for those
No, we're
services.
not billing. No, we're
So,
not billing.
um,
But it's just a community outreach.
I know you have a focus on prenatal and women's health. Since this pandemic, we've extended the benefits for postpartum care. Have you seen any decline in mortality, infant and maternal?
You know, it's a little early for some of that. We have seen an increase in engagement on the postpartum side with our care managers. So that's an early indicator. As far as long-term, we are tracking that to see what that's going to look like, but we're very focused on that piece of things. We think it's important to have that additional benefit, which is why we're doing things like working with WIC and putting some programs in place that might extend past you know, that 60, 90 days that they have postpartum.
All right, thank you. Okay, Senator Blunt. Senator Wiggins, you have a question?
No, Mr. Chairman.
Right, thank you. Thank you, Bridget.
Thank you.
We have J. Michael Parnell up. He's the Chief Executive Officer of UnitedHealthcare.
Thank you, Mr. Chairman. Similar to Mr. Snyder, I submitted a handout beforehand. Hopefully the committee members have it. I have extras if anybody wants to raise their hand and have one for themselves. There's a lot in that handout, so I won't refer to it and read it point by point, but it shows a lot of the stuff that we're doing in Mississippi. One of the items we were specifically asked to address was the population we serve. It's not very dissimilar from what you've heard already. We serve over 200,000 members in Mississippi, and right now that is the Medicaid population through the Mississippi Coordinated Access Network, or Mississippi CAN. We also are serving the CHIP members, and we are in the state for doing dual eligible Medicare, Medicaid. And that is a growing area. We should be statewide by next year. I think the one of the good things about going at the end after my colleagues presented from Molina and Magnolia is that you get a flavor of the program. And you heard from our first two speakers, Ms. Blanford and Ms. Kidder, that you know, the savings are real. And I think that Senator Blackman asked a question early on, if there have been any MCO programs across the country that lose money that are in certain types of models or whatever. I mean, I can assure you that yes, that is a risk that the managed care organizations bear, and it is part of the rate setting process that you've heard a lot of people talk about today. We know that times we may have medical expenses that exceed the capitation payments, and it's a risk that organizations like ours take because we anticipate the following year staying in the market and being able to work with actuaries to see that claims experience and services were more costly than anticipated. So we stay in the market, and the rates usually fluctuate with that. You heard Mr. Snyder talk about the 87.5% MLR, or medical loss ratio, meaning that the capitated payments paid to the managed care organizations under the managed Medicaid program, 87.5% are expected to go to provider reimbursement. Anything beyond that, if we are paying providers less than expected, the rebates in place, that guardrail's in place. And I think that's a theme that I heard throughout the day, and I totally adjusted kind of how I was going to approach this today. I was going to go point by point by my handout. But I think the message that I want to make sure that everybody understands is there are guardrails in place. There are guardrails in place that are built into the contract. The financial guardrails being the medical loss ratio, the MLRs, currently sitting at 87.5%. we pay money back to the state. You heard Mr. Snyder talk about the payments directly to the state through revenue, through insurance premium tax and income tax. Our portion is right around $40 million, and that's just one of three of us. And also what's being paid back at that MLR or risk corridor. Risk corridor is what you refer to it as, but it's essentially that MLR payback. And I can assure you that there are many millions of dollars getting paid back into the state right now because COVID, I think just about everybody's mentioned COVID so far, and we're all thinking about it. COVID has impacted activity significantly. Services went down, people couldn't go in, elective procedures were canceled, scheduled procedures were canceled or deferred. And that really put off high cost care. So our payouts to providers were less than anticipated. So we are currently paying back the state right now dollars because we did not pay providers what was anticipated through that rate setting process. Now, what's going to happen as a registered nurse, I can tell you it scares me in a year or two from now when all this primary preventive care was deferred. I anticipate people going back in for high acuity reasons, but that's something that we'll manage when we get there, and we'll adjust that through rate setting in subsequent years. So in addition to the financial guardrails, one thing that I think was not, well, I know it wasn't mentioned today because I kept wondering who's going to mention it. The question I believe you asked, Mr. Chairman, about preventing the premium slide. The Mississippi system is actually set up pretty nicely for the taxpayers in the state, where the managed care organizations are what's called community rated, meaning that when the actuaries set the rates, they take experience from all three of us and look at everybody's claims. So United, my claims are pooled with Molina and Magnolia. The actuaries review everybody's and is community rated, meaning all three of our claims are taken into account. I don't have UnitedHealthcare rates. Will and his team, they don't have Centene or Magnolia rates, and Bridget's team doesn't have Molina rates. We're all held to that same, each rate cell is compensated the same, no matter what MCO they set in. So what really prevents premium slide is essentially I'm competing against them to deliver higher quality, more cost-effective care. So they are, as Will said, a competition to make sure that we're delivering in a financially effective way, and we're consistently driving that curve downward, and we're operating to push quality and lower cost care settings to deliver that care. So that is the safeguard that's in place as well, and also helps mitigate premium slide that you asked about. The quality guardrails, I think it's really important that that we are held accountable as managed care organizations. It's in our contract. It's expected from the state that we're held accountable for certain at-risk measures that are HEDIS measures. I believe the first two speakers both spoke about HEDIS. So that's primary preventive care. It's care that's specific to certain disease processes, hemoglobin A1C for diabetics, things like that. Child wellness, we are held accountable for certain child wellness. We're a little over 70% pediatric in my health plan, and I think that y'all's are probably pretty similar. The Medicaid program in Mississippi serves a disproportionately larger amount of kids than it does adults. So the child wellness is a big thing that we're held accountable to, and we're actually at risk. 2% of our premiums, I believe, are at risk for withhold if we don't hit certain quality measures. Readmissions to hospitals. So post-discharge readmissions, we're held accountable to that, just like many hospitals are in the QIPP program that Medicaid also runs. The ER representations following discharge, that's another measure that we're held accountable to, and we manage that constantly. Our case management process is really designed to interact directly with members who are discharged, medication management for discharged patients. High risk, we risk stratify all of our members or patients, so we know who's more at risk for triggering these events that lead to higher cost and poor quality outcomes. Access guardrails. So I think that's an important guardrail to let everyone know about, or remind people that we as a managed care organization are held accountable for access of our members. We have to comply to certain geographic access standards. We have to have providers within our network who provide after hours, 24-hour care. After hour care, it's not just you pick up the phone, call your doctor, and the message says you go to the ER. They have to have a valid place to direct care to take care of the member. We have our own internal triage processes, nurse lines to triage for lower acuity, et cetera. But that's another guardrail that we have in place. Operating guardrails. We hear a lot of times that we're not getting paid by the managed care organization or, yeah, I mean, they're currently Senate Bill 2799. We cannot go below the state fee schedule. I mean, we are at Medicaid as our floor for payment models. Preferred drug list. We follow the same preferred drug list that Medicaid does, the other MCOs cover, and the PA processes that was put in place this last go around. I think it's very good that we are all unified on prior authorization process. As a former hospital administrator and physician practice administrator, I know the hurdles of dealing with multiple payers, multiple insurance companies, and trying to find out, do I need PA for this? Do I not need prior authorization for that? It depends on the payer. I mean, you walk in some offices, they have sticker or pages taped on the wall of, you can name the insurance company and what requires PA and what number do you call, and they can rip it off and change it the next month. So I think there are certain operating guardrails that are in place that are it's very friendly for the healthcare delivery system in Mississippi. So outside of the guardrails, I think, from my perspective, I think what I would like to see the direction of healthcare go in Mississippi, I think it would be beneficial if we do move more toward a value-based care delivery model. CMS has said APMs or alternative payment models should be the direction of the future, and there are certain percentages that are required at certain health plans and payment methodologies, including state programs. So I think moving toward a value-based arrangement would benefit us. Here at UnitedHealthcare, we have a variety of options, meaning we book over $7 million a year to expect to pay providers for incentives. It's upside only. So the providers really just have to document the work or do the screenings or do the preventive care, and they just get extra money on top of their payments. We have shared savings models that are in place right now that as providers render certain primary and preventive care, we know that the primary and preventive care, it pays off in the future, because if somebody's getting effective primary and preventive care, the chances of them landing in the ER is much lower. The chances of them being admitted to the hospital is much lower. So that's what calls it accumulates savings of dollars that we know that's going to prevent higher costs later. And we share in those savings and pay providers out on those ACSS, we call them, which is kind of an ACO light. We don't do risk-based. We can't do risk-based in Mississippi. We have provider interest who are always asking, we're willing to do a risk-based model. So if somebody's willing to say, we'll go to a contract rate of 90% if, you'll pay me 125% if I hit certain measures, we'd love to be able to do that. Right now, we're not there. I understand the hesitation because for 10 years, as Mr. Snyder said, managed care has been here. And 10 years ago, I'll tell you, I was working at a provider, at a hospital actually. And when it was being socialized, it was, they're going to pay us the state pay. They're going to pay us the state pay. They're going to pay us the state pay. And then we heard, okay, managed care is coming in. Managed care organizations can do VBCs. Yes, we can. We can't now, but we'd love to be able to do that. But essentially, it puts everyone within the health system of assuming some level of risk to drive for quality, for outcomes. I think probably the last thing that I would ask, I think that it would be really good to have certain mandates in place to have providers work with managed care organizations. As a former hospital administrator, when I talk to some of my former colleagues, I'll say, it's very easy for you to know what goes on within your four walls. Once they're gone, do you know if they filled that prescription? Do you know if they followed up with their PT appointment? Do you know if they followed up with their endocrinologist afterwards? I do, and to be able to share that data, partner with providers more. We have some very good partners across the state. We'd like to engage all of them across the state. So I think that's kind of bringing it all together, and that's the UnitedHealthcare perspective, but happy to entertain any questions, including any questions you asked any of the others. So.
Thank you for coming. I really don't have anything. Senator Bryan, Senator Wiggins, you still with us? Is he gone? All right.
I'm sorry, Mr. Chairman, I'm here. No questions.
All right. Thank you, Dr. Purnell.
Thank you. Michael's fine.
Next, Tim Moore with the Hospital Association.
Mr. Chairman, we're going to tag team you today, if that's okay.
Are you
And,
tag teaming with Richard,
with
Mr.
Richard
Cooley?
Robertson. Yes, sir.
Robertson? All right.
And we'll do that quickly. In the essence of time, I learned a long time ago that the mind only absorbs as much as the seat will bear. So
Understand.
we'll move on quickly. Just to say thank you on behalf of the industry. It's always an honor to come before this group and share our thoughts. And it couldn't come more timely as we come out of a pandemic and possibly prepare for another critical time in our health system's history with no doubt the greatest strain on our labor force that we've ever experienced in history. So the timing of trying to work through issues with payers of any type, including MCOs, and as one of our hospital administrators puts it, eliminate or decrease the hassle factor. It couldn't come at a more important time as we go forward. Mr. Chairman, you made a good point earlier that we've all seen our costs go up, particularly in labor, but we've not seen our reimbursement go up. And for our hospitals across the state of Mississippi, it's becoming a greater challenge each and every day. I'll share this and then I'll ask Richard to come forward and share some facts that have been put together to hopefully help guide you through this process. I received a letter that was coming out this morning from a health system in North Mississippi that is anticipating the closure of 500 beds across the system, strictly due to a shortage of staff to be able to take care of potential flu and additional COVID cases that could come back up. We are seeing slight increase in numbers now. And of course, now the flu cases are coming. So a lot of things, and that doesn't have anything to do with managed care other than the fact that we have to try to find ways to reimburse our providers in order to keep the doors open. When Richard and I talked about coming before this committee and having a discussion on what needs to be presented, how do we need to approach this? And certainly we can always come back with anecdotal stories and talk about various things and hypotheticals, but we felt like this time it may be better just to share facts, unbiased, straightforward facts that are pulled from third-party sources that you can look at and you can make a determination, are the taxpayers in the state of Mississippi getting their money's worth? Is the system right? Are the vendors right? Just an opportunity to look and see what we have and then make a decision. That's all we ask today. Most of you know Richard. Richard is our Vice President of Government Affairs. He is also our General Counsel at MHA. And at this time, I will turn the podium over to him if that's okay with you, Mr. Chairman.
Good afternoon, Mr. Chairman and members of the committee. I'm Richard Robertson. I'm Vice President for Policy and State Advocacy with Mississippi Hospital Association, also General Counsel. And as many of you know, spent a good deal of my career before coming to MHA, both at the Division of Medicaid, the Attorney General's office, and also in private practice. So it's a pleasure for me to be back with you today. And we just want to go through, as Tim said, and share some snapshots about where we are as an industry as it relates to payers, and then specifically get into a discussion about managed care. So I think it's really important to know when we talk about healthcare, there are costs, there's expenses involved, and then on the revenue side, you've got to be able to make sure that your payers are paying you enough to cover your expenses. That's any business. Hospitals are no different. There's a lot of talk about healthcare expenses and going up, and certainly they are going up, primarily driven up because of labor issues lately. But what you need to know is that Mississippi's hospital expenses, inpatient per diem expenses, are among the lowest in the country. We can't cut into the bone on expenses much lower than we're already cutting. The issue in Mississippi is not a cost problem, it is a revenue problem. Our nonprofit hospitals had the lowest national inpatient per diem expenses. Our state and local government hospitals are the 9th lowest, and our for-profits are the 6th lowest. They're managing their expenses, they're controlling their costs, and these are fractional compared to the higher cost states. So where does the revenue come from? In Mississippi, this is the pie chart that shows you our hospital expenditure or our hospital revenue sources. 35% Medicare, 9% Medicare Advantage. Okay, this is on the inpatient side. So right out of the gate, about 44% of the payer mix for our Mississippi hospitals is coming from Medicare, Medicare Advantage plans. When you throw in Champus, TRICARE, VA, that's another 2%. So now you're over, 46, 47% revenue coming from Medicare, Medicare Advantage. And then you throw in the Medicaid fee-for-service and United, Magnolia, Molina, and that's another 22%, because there's another 1% out there that comes from our neighboring state Medicaid programs. Our hospitals in South Haven and Corinth, along the coast, in Vicksburg, and even here in Jackson, get a fair number of Medicaid patients from other states that cross the borders. Meridian also, Tupelo also. So about 1% of the payer mix in Mississippi actually comes from out-of-state Medicaid payments. 4% from Mississippi Medicaid fee-for-service, and then the rest from Medicaid is from Medicaid managed care. Throw in about 9% coming from self-pay and charity care. So you're pushing 80% between the federal payers, the state Medicaid payers and state MCOs, and your self-pay, which is pretty much your uninsured, okay? That leaves very little for commercial payers such as Blue Cross Blue Shield and other forms of commercial insurance. That's about 10%, but of that commercial insurance, you have your federal marketplace plans such as Ambetter. So you've got marketplace plans mixed in with commercial insurance. They do freely negotiate rates, but it's a little bit different equation when you're negotiating the commercial rates for employer covered plans like Blue Cross. So it's a very challenging payer mix where you're trying to make ends meet, where Medicare is going to pay you right at or maybe right above your cost. Before sequestration cuts, sequestration cut 2% off of that. So now you're back down to right at your margin, or right at your cost. And then Medicaid pays you right at or right below your cost typically as well. So that other 20% of commercial basically has to try to make up for the 80% that pays you right at your cost. So there's very, very little margin to be made. On the outpatient side, it's not a whole lot different. Again, it's primarily Medicare, Medicare Advantage. You do have more Blue Cross and commercial insurance on the outpatient side. Together, it's about 31% commercial, 38% Medicare, Medicare Advantage, 20% Medicaid and the Medicaid managed care companies. But again, it just stresses the challenge of trying to make ends meet with this type of payer mix. It is extremely difficult for your hospitals in Mississippi to survive, much less thrive, with this type of challenge.
Richard, could I ask
Yes,
you
sir.
just a question real fast, since you're on your slides? When you're talking about Magnolia and United and Molina and the percentages they have, is that Medicaid, or are they
Yes, sir.
included in that 4% Medicaid?
That is the Medicaid managed care plan, United, and that is in addition to the Mississippi Medicaid 4% is Medicaid fee for service. Those are your dual eligibles. Those are your non-managed care enrolled Medicaid members.
Don't the three managed care have regular commercial products, managed care?
They do. Well, Magnolia does with Ambetter as part of that plan, but that's not part of this.
Where would those figures come in? Would that be under your commercial insurance?
That would come into our commercial
Okay.
insurance.
All right.
Yes, sir.
Thanks.
So when you look at your Medicaid managed care plan and you look at the filings with the Department of Insurance, every year, all health plans in Mississippi file reports with our Mississippi Insurance Department. You can go to the market share analysis. You can get a profile of the percentage, basically the percent covered lives in the state, the percent of their market share of the state as a whole. You can get their premiums earned, their losses expended, and you can get a pretty good snapshot of what the healthcare industry or any health insurance product, and life insurance as well, looks like. Between calendar years 2011 and calendar years 2020, there is a $2.1 billion spread which is the difference between the premiums earned and the losses incurred. I'm not going to call that pure administrative cost, but it's pretty dang close. In calendar year 2020, the COVID pandemic, the lack of healthcare availability, procedures, elective procedures, basically closing by order of the state, people not accessing healthcare services, the expenditures across the board, okay, for commercial insurance companies, for Medicare Advantage, and for the Medicaid managed care companies, the expenditures on healthcare were extremely low compared to what they typically are. It resulted in a difference in premiums earned and losses incurred that the plans are reporting of about $500 billion. That's about twice what it normally is. And that equates to about 80% of the premiums. So if you look at the reported loss ratios from the three managed care plans, it's about 83% for Magnolia, about 79, almost 80% for United, and about 75% for Molina. That's reflective of a lot of things that happened in healthcare because of COVID last year, and people just not accessing the services. And each speaker, I think, has talked about the risk corridors where there's a settling up. So in a situation like this, where planned payouts were not what was expected and the capitated payments weren't fully utilized for what they were intended, then there is a payback to the state. I think in the Medicaid's LBO presentation, they've estimated about 154 million coming back from the Medicaid managed care plans, and then another 35 million coming back from CHIP. So a total of about 180 million. I'm assuming that's federal and state dollars. So, so a portion of that would have to come back to the state as part of those risk corridor adjustments. Yes, sir.
Sorry to interrupt you, but as long as you're on some of these slides, I'd like to ask you a question. All right, so Magnolia gave us a presentation here saying Magnolia was at 90.9, United 89.0, Molina 88.1 for the year 2020. So your numbers are significantly different. So
I don't know where their numbers are coming from. They may be state fiscal year 2020. These are calendar year 2020. So that could be part of it.
All right.
But this is taken from the Department of Insurance filings that those companies make with the Department of Insurance.
Right. Will, do you happen to know?
I would have to see these and pull ours. I mean, we don't have enough information.
All right. Maybe as a follow-up, I'd like to just get some clarification because we're looking at two totally different sets of numbers. So
Yes, sir.
all right, thank you.
This information all came from the company market share analysis reported on the Mississippi Insurance Department website for calendar year 2020. And you just run the math, take the charts, and this is where it shakes out.
All right, thank you.
So if you look at those company market share reports reported by these companies to the insurance department in Mississippi for calendar years, okay, not state fiscal years, but calendar years 15 through 20, this is kind of the snapshot that you get. The average Mississippi can enrollment, that comes from Medicaid data. The other data comes from those market share reports, and that's where you'll see the differences between premiums paid, losses incurred, and what I call admin, because I think that is a fair representation of it, but maybe a term of art people can distinguish. The percent of losses to premiums typically hovers in the high 80s, around 90 maybe, but then last year it was down to 80. That is a challenge for your providers as well, because there are fixed costs in healthcare, whether people access the system or not, that just don't get made. And of course, that's been the story of COVID across many industries. So when you pay a company to provide a service, what do you get for that service? There are the National Center for Quality, the NCQA, HEDIS scores, kind of a national program. You can go to that. You can pull up the quality scores for all health plans in every state, commercial, Medicare Advantage, and Medicaid. I went ahead and pulled those down and dropped them into a chart for you guys. They basically fall along three big categories. One is they evaluate the plans on how well they do with the patient experience. How well do the patients believe and feel that they're getting taken care of by the providers in the network and by their health plan? When you look at this across the board, our plans do really pretty well. Magnolia scores 4s and 5s in their patient experience measurements, satisfaction with plan physicians, primary care doctors, rating of care, and the rating of the health plan by their patients. Molina's a little bit lower in some areas. United's about the same. They're all pretty comparable. You see a lot of 3s, a lot of 4s, a couple of 5s, and some 4.5s in here. So those are all pretty good. And nationally, when you look at patient experience scores across the board for most health plans, the patient experience scores tend to be higher than what they do for these next set of scores. So this is pretty comparable to what you should expect and what you should see nationally. When you look at the different things that equate to preventive services, or how well do the health plans score on quality for prevention, these are the scores that you can go pull off the NCQA website. This is the most recent year available. And I should say too, for the last year, because of COVID and because of all the variables therein, NCQA has allowed plans, and NCQA is reporting out basically the highest score of the last couple of years, so that one year in particular doesn't just be an outlier and ding the plan unfairly. So these would be the highest scores, perhaps this past year, but it could have also been the highest score from a couple of years ago that NCQA is basically doing an aggregate data pull for the last couple of years. So you see a lot of 2s, a lot of 1.5s, some 3s, a couple of 4s, and a few 5s, particularly on prenatal care, where all the plans, and Molina spoke to this about the focus on prenatal care, good marks on preventive scores on prenatal care. The other big area is treatment, and how well do the plans score on that? And so you'll see here a lot of 2 5s, a lot of 4s, a couple of 4s, 1 5, and several 2s and 1s. And I should say 5 is the highest, 1 is the lowest. But things like controlling high blood pressure across the board, 2s, heart disease, these are things that we've got to do better at if we're going to move the needle. Because when I was at Medicaid and we started into the managed care experience, the reason to get into it really boils down to saving money by improving healthcare outcomes. I mean, if we just wanted to save money, the legislature could cut the rates. You could issue a law, promulgate a law that says we're going to reduce spending by 10%. Okay, well, now you've saved money. If we wanted to just simply save money, we could do that by just cutting out rates. Okay, but the way to do it appropriately is to improve the healthcare outcomes so you don't have repeat visits, and so you don't have people continuing to suffer from the same illnesses or unchecked illnesses that lead to higher cost over time. Here's some more treatment scores. These particularly related to mental health get at one of the questions from earlier on how well we're doing with mental illness. And a lot of 2s and 2 5s. We do have 1 5 there on adhering to depression medication for 6 months, where Molina appears to stand out in that regard on the NCQA scores. So a lot of work still to be done on treatment on many of these issues. And, again, all this is taken from the NCQA website. Finally, just the last slide on that, just to conclude it, just to give you the full snapshot. More of the treatment scores. Sore throat, we score right in the middle, which is good because that's something that we do have all the time with kids, and primarily the kids are the main population in managed care. So I shared a similar slide with you the last time we talked about managed care. Just an update. This is on the Division of Medicaid's website. It's just the history of liquidated damages. Just a couple in the last year. Little under 1.7 million in liquidated damages from the managed care plan. So if you talk about $1.7 million is a lot of money to me. If you talk about billions of dollars a year in premiums and all the different evaluations and criteria that get measured, it's not a significant amount of money, but no one wants to have to pay back any money. And then this past year, of course, the announcement that's already been touched on with the $55.5 million settlement with Centene. And so that was kind of the big outlier. We probably have not recovered that much in provider fraud from the Medicaid program in the last 10 years. So what did the legislature do to address some of these concerns that y'all have heard about from providers? And yeah, it probably does get a little ramped up a few months before the session, just like everything probably does for y'all. But that doesn't mean that they're not out there all the time. And it doesn't mean that they're just anecdotal, made up stories. These are real stories from real providers or real patients that have had problems. Y'all responded to that last year in several ways. So in Senate Bill 2799 from last session, you put a provision in that says if Medicaid reduces the rates to providers because of a budget overrun or a budget shortfall, then Medicaid must reduce the managed care profit and admin fees correspondingly. That shows the providers that, hey, we're all in this together. MCOs are prohibited from implementing more stringent requirements for prior authorization, utilization review, those sorts of things than what Medicaid can do. And they're supposed to submit a status report to you by December 2nd on how well they've done with that. The point of that provision was really to try to standardize and eliminate some of the red tape, the administrative hassle. Providers know how to follow rules. They know how to do utilization review. They know how to file a prior authorization. They do it all the time with a litany of health insurance companies. But for whatever reason, this program has been wrought with more hurdles and hassle factors from what we hear from other providers than other programs are. So this was an attempt to try to streamline some of that and try to reduce that, because each one of those hassle factors or hurdles is an additional cost to the system and a cost that has to be paid for by someone somewhere. The legislature deleted the requirement that the managed care companies provide unrestricted access to hemophilia factor. The managed care companies were all required to adopt level of care guidelines to determine medical necessity. Again, an attempt to try to standardize and try to make things more efficient for the program. And it's agnostic which level of care guidelines you adopt, just adopt the same ones and have them apply to everyone in the same way. Managed care companies are required to share their administrative cost data annually, as well as the number of FTEs that are dedicated to the contracts. We've heard some of that today. The MCO is required to adopt a standardized credentialing process by December 1st. So tomorrow, and if not, then Medicaid would have to adopt one by 7/1 of 2022. So again, that's additional information. There are some provisions for temporary credentialing that are super important for providers and for their patients, because if you're trying to recruit a physician to your area and your area is heavily dependent on Medicaid and or Medicaid managed care as a source of revenue, you've got to be able to get that provider credentialed. You've got to let them see patients and create revenue to help attract them to your community. So really, this is as much of a physician recruitment tool as anything else that we talk about with physician workforce. If you're not going to get paid for a year and a half because you can't get credentialed by a health plan, then it makes it extremely hard to try to recruit someone. So this is an important provision in here to allow temporary credentialing, to expedite that process and to try to standardize it. The MCOs must also now detail the reasons for any denials, and they have to disclose the name and credentials of the person who denied the coverage. The idea there being that you would not have, let's say, an RN denying a claim or a service that's been requested by a cardiovascular surgeon for a patient that's in significant need. So it's an attempt to align the credentials, and it's an attempt to make sure that that process is more transparent. There's also provisions to require Medicaid and the managed care companies to expedite the appeals process to make that move along more quickly. There's been a lot of complaints about the delays in the appeals process there, and I think Medicaid has taken some steps in that regard. There's also a clear expression of legislative intent for the MCOs to implement innovative programs, again, to improve the health outcomes for members with diabetes, pre-diabetes. That's well documented, the high need and the acuity level of our patients in Mississippi with diabetes. Legislative intent for the managed care companies to improve utilizations of the LARCs, the long-acting contraceptive pieces, to submit a report to you by December 1. So that should be coming to you. You have a lot of reports in the next couple of days. So we appreciate from the provider standpoint, the legislature's taking this seriously. The legislature responding to the work that the provider groups put in. We convened starting back in last summer to try to get all the provider groups together to talk about Medicaid. We invited legislators, we invited the Medicaid agency, we invited different stakeholders to come and talk about just the process so we can get it right. We don't need to be making these types of policy decisions in a vacuum. Y'all don't need one person running in and out of your office followed by the next person running in and out. So what we tried to do is bring folks together in a setting where we could talk about things and introduce the concepts and work through those. And we appreciate the legislature being responsive to that. So I'm glad to stop there and try to answer any questions.
Thank you. What percent of your hospital business is fee for service?
Well, if you look at, the Medicare, most of the Medicare payments are going to be fee for service. Medicare Advantage is going to be a fee for service type of payment, the Medicaid fee for service. When you talk about fee for service, it's basically a rate paid for a service provided. It's not the value-based payment. So far and away, the majority right now is still in a fee for service model.
Thank you. Any other members have questions? Senator Blunt.
Thank you, Mr. Chairman. Thank you, Richard. You showed some charts that measure patient satisfaction with the 3 different companies in a variety of services. Is there any way to measure provider satisfaction among the different types of providers with the 3 different companies, and any way to measure among the different providers out there how they feel like the different companies are responding to them?
Yeah, there's, this is all part of a HEDIS score. There's no HEDIS score equivalent. Y'all get that every year through the legislative process. You hear provider satisfaction.
Well, it's just anecdotal.
Yeah, there's not a formal survey that I'm aware of that's being used on a national scale that kind of normalizes some of the data that like the HEDIS scores would. Internally, I think Medicaid meets with stakeholders and as well as the plans do to hear from them. So I'm sure, again, it's anecdotal. There's not a formal objective survey tool that I'm aware of.
And I should have asked Mr. Snyder this when he was here earlier, but if there is a RFP out for managed care providers and some of those, and the 3 companies that are in business right now in Mississippi respond to that, it would seem to me that it would be important for the Division of Medicaid, if they are scoring those proposals, to hear from people in the state who have worked with these companies about how they feel like they're doing and how they're being treated. How would that be done?
I'm not sure how Medicaid would try to capture that information. I'm sure it could be captured. I mean, there are tools out there you can do a survey on just about anything.
Yeah.
So yeah, it could be captured. I'm not sure how if that would be part of their calculus on determining the RFP process, or how they might factor that in.
Yeah. Well, it would seem like it would have to be, because you've got, for at least the 3 companies that are here, you've got real world experience on how they're doing. I didn't hear from you with regard to Medicaid delivery or anything else, what your 2022 ask is going to be, or what we need to do to help hospitals or help specifically on Medicaid related issues with hospitals.
Yeah.
Do you have anything you want us to think about?
Loaded question. Yeah, you know, and we were focused on the.
Well,
on the
and I don't mean
managed
to,
care
I don't
piece,
mean
but-
to, I'd like to hear
Yeah.
the big issues, but I don't mean to, I want to hear the other things that from across the range of what may be achievable and possible, what you think we need to think about.
Yeah, I mean, you know, aside from the single biggest thing that we could do in healthcare, which is expand coverage, and the federal government appears to be working through a solution which would address a significant issue for hospitals, which is that uncompensated care.
Right.
That as a result of that, hospitals across the industry are down about, or underwater about $11 million a month. If you could change the impact of uncompensated care and cut that in half, you would restore hospitals, you would have a nose above water situation for the industry. So that's important. And there appears to be, you know, a bill moving through Congress. We'll see what happens with it that might achieve that. From a state perspective, you know, as Tim alluded to, it's workforce issues. It's the challenges of retaining and attracting staff, particularly nurses right now, but also physicians. We looked at this a few months ago. The physician population in Mississippi, the percent of physicians in Mississippi over the age of 55 is greater than it was 20 years ago. So you've got an aging physician workforce that's going to have to be addressed. And we're going to have to come up with some ways to attract physicians here as well. And so hospitals are changing. Hospitals have changed dramatically in the last decade. The inpatient outpatient mix, the percent of revenue coming from outpatient services versus inpatient services has virtually flipped over the last 10, 15 years. So the models and the delivery of care from the hospital's perspective, totally different than it was 10, 15 years ago, which leads to some of those decreased expenditures and why we've got low expenses in Mississippi. But our primary challenge in Mississippi and hospitals is not that we can't figure out how to do things at a lower cost. It is that we cannot get the revenue we need to cover those low costs. So that's going to continue to be our challenge. So whether it's, you know, in the form of increasing revenue for hospitals, decreasing the tax burden on hospitals, hospitals fund in a normal year about $280 million in taxes to fund this program. So that's a huge issue. So we've got to figure out some ways to stabilize revenue so that you can stabilize workforce. So then you can do all the things that you need to do to have a healthy healthcare system, and which then leads out to a healthier economy, healthier workforce, and all that.
Well, I hope you would work with your partners in the Medical Association, Nurses Association, and come with a proposal for us to deal with these workforce issues.
Appreciate it. We will be doing
Thank
that.
you. Thank you.
Senator Bryan.
Could you go back to the first slide, please, that showed the cost in various hospitals when you were explaining how cheap hospitals are in Mississippi? Now that one, it says that the government hospitals are $1,218 a day, nonprofits are $1,234 a day, and the for-profits are $1,645 a day. It looks to me like that's a pretty good argument for socialized medicine. Mr. Chairman, I move we rise and report.
Senator Wiggins, are you still with us?
I am. Can you hear me, Mr. Chairman?
I can. Any questions?
Yes, and I'm sorry, the live stream is not working, so I think I can only talk and listen.
We actually see in the, well, we did see it, or we can see up in the top right-hand corner of the
Okay,
screen.
thanks. So a couple questions, Richard, on this, the providers that you keep mentioning, who are the providers that were in this, I guess, group?
From last session?
Well, no, you said that the providers got together and, you know, talked about these issues with managed care, which is totally fine. I'm just trying to figure out who the providers are.
Yeah, we had stakeholders representing pediatricians, state medical was involved, the Academy of Family Physicians was involved, independent pharmacy, the Mississippi Pharmacy Association, the long-term care associations, both of them were involved. We had Division of Medicaid was there. Different legislative committee chairmen came and were invited. I think we did every one of them via Zoom. Representatives from the governor's office, lieutenant governor's office, and the speaker's office were invited to these meetings. We had, I think, DME came in at one point. I think ambulance was represented at one point. So several different provider groups. FQHCs, I think, were in there. The community mental health centers were involved. Hospitals, obviously.
Okay, thanks. So was this outside the Medicaid provider advisory committee?
Yes.
Okay. So why did you see fit to do it outside of the Medicaid advisory committee, since the Medicaid advisory committee is actually a federal requirement that's set up for providers to talk to Medicaid and advise them?
Because I don't think those members have been appointed by the governor, and I don't think they had met since the end of 2019.
Fair enough. So it sounded to me like in your presentation that with the legislation that we did, that we actually, as I guess a legislature, made fixes to the managed care program that seemed to address a number of the things. I mean, you would agree with that, right?
Yes.
Okay. So is the point of the presentation to highlight these problems, which, and I know there's these issues, is the point to highlight these issues so we can do more legislation, or is it to, I guess, say managed care is not necessary?
No, the point is not to say managed care is not necessary. The point is to spotlight what was done last year, to remind the committee what was done last year, to address the concerns that the provider community had expressed, and the legislative action that was taken last year. I think, Director Snyder said there are pros and cons to managed care, and I'm not debating the pros and cons of managed care. You can debate the pros and cons of a football team and what the problems may be, but at the end of the day, most of the time schools keep a football team. They may fire a coach, but they keep the football team. So I'm not debating managed care or whether it is working, has worked, can work, would work, should work. I'm just laying out what is going on now and what the legislature, I think, needs to know.
Fair enough. And Director Snyder did also say that there's a $20 million return to the state general fund. And he, as well as a number of the other presenters, also said that managed care and Medicaid is the standard, or certainly within the majority of the states across the country. You heard him say that, right?
Yeah, we've also got a majority of the states that have expanded Medicaid. And if you look at what the state paid in administrative cost, the state share of the administrative cost to get the federal share of the premium tax, if you look at that over the history of the program, over the 10, 11-year history of the program, the net gain to the state of Mississippi is just over $11 million, or about $1 million a year.
Right. And I appreciate y'all's position, which has been to expand Medicaid or expand like the other states. And that brings me to the point that what I hear is give me more money, and not how do we, at least not from in this presentation, how we control the costs and how we affect that, how we do that. It's give me more money so that we can justify where we are when, as what we heard from some other presenters is, let's try to bend the curve of the healthcare costs in this state and country. And I didn't see in your presentation a solution for this about controlling and bending the curve on healthcare costs. Do y'all have a solution to that?
Well, I've shared with you, and what's on the screen right now are the expenses it's hard to get much lower on holding the line on cost. So we can talk about costs, and we're glad to have that conversation. But when you're already the lowest cost per day for nonprofit hospitals, the 9th lowest for state and local government hospitals, and the 6th lowest in for-profit hospitals, I'd submit to you, your problem is not cost. The problem is revenue. And, we can talk about the various ways to increase revenue. We can talk about various ways to decrease cost, but, and we're glad to do that. But I would submit to you, the cost of hospital care in Mississippi is the lowest in the country. And I don't know how to improve on that. We can keep working at cut. I mean, we can cut staff, we can cut physician salaries, we can cut, we can cut things like that, but that does not improve patient care when you do that. And it doesn't improve economies either.
Well, I think, and I'm coming at it from what I call the average Joe, okay? And my local hospital, and I talk to that quote average Joe all the time. And when they get their hospital bill, it says, and I'm just making something up, but it's representative, it's $20-something thousand, okay? And then it gets all these breakdowns from depending on which insurance company paid this and which insurance company paid that. The average person doesn't understand what hospitals, the charges that get done. And we could spend hours and hours talking about that. But if costs are as low as they are, then how come when a bill is sent to me as a patient at a government-run hospital, that the numbers are something that nobody can understand? Why, if they're as low as they are, then how come anesthesia is X thousands of dollars, but lo and behold, when you come in and you factor it and then you go back to them and you say, you know what, can you reduce it? Oh, we'll reduce it if it's as low as it possibly can. Do you understand my question?
Yeah, it's kind of like lawyer bills. When you get those and you have never met the associate that's name appears on the bill, I guess. But
no, it's not like that, because when I'm a lawyer who sends out bills, I talk to my clients and I tell them exactly what it is up front. So it's not the same with all due respect.
Well, I think it's pretty similar. No one likes to pay lawyer bills either. But, from the hospital standpoint, what you have also is a disconnect between insurance company network providers, out-of-network providers. There's been federal legislation to address that. There's now transparency issues with hospitals, publicizing costs and charge, and a lot of money has been spent on software to try to help consumers put in their insurance information, run that through the expected procedures that they're trying to avail themselves of, and try to get a cost. So there's a lot of work being done. If you go in and you talk with the hospital prior to your procedure, you're going to get a pretty accurate representation of what your costs are going to be. Now, if you're on the table and something happens, I don't think they're going to bring you up from anesthesia to ask, hey, by the way, this is going to cost a little bit more. Do you want us to go ahead and do this? Do you want us to go ahead and fix it now while we got you open? So there's always those types of things that are unexpected that are going to happen. But I think by and large, the hospitals do a pretty good job of communicating those prices in advance, working with the insurance companies and the patients to get those managed and under control. And, and folks, I think, typically are told when you get that first bill, wait till it goes through a cycle. I think we've all had sticker shock from various bills that you might get, but wait until it goes through your payer before you stroke a check to the hospital or to the anesthesiology group or any physician or medical provider.
For the record, that's not how attorneys operate. I tell them what the cost is, and they know what the cost and exactly what they're going to pay. And I will beg to differ on you that the patients go in and sit down and they're told how much it costs. They never do that. And I've had people tell me that, and I've been through that. And if you're telling me that the hospitals sit down with the folks ahead of time and go, you know what, it's going to cost X amount of dollars and X amount of dollars. That does not happen based on the people that I talk to. And then they get a bill from the hospital, and then they get a bill from the emergency room physician, and then they get a bill from the anesthesiologist, and then they get a bill from the lab, and then they get a bill from all these other people. In the meantime, the average Joe's head is spinning because they can't keep up, because the hospitals in general have made it so complicated. If it would be easier, then I think we could get to somewhere. But that goes back to my point of a solution-oriented proposal from the Mississippi Hospital Association. In 6 years, I've never, me personally, but also the legislature hasn't received that. It's always about, give me more money. When are we going to talk solutions for the average Joe?
Mr. Chairman, I don't know where you've been for the last several years, but we've come with numerous solutions to the legislature about ways to address healthcare. We've worked with the legislature on several bills. We worked with you on a transparency bill several years ago on open meetings and open records.
No, you didn't. You actually fought that, for the record, but that's in the past.
We worked to make the bill actually passable for you. And so we worked on that with you.
Richard, with all due
Mr. Chairman,
respect.
I don't think you want to go down this road, but if you want to air it out, we can certainly do that.
For the record, and no, I don't want to go down the road because this is neither the time nor the place. However, no, you didn't make it passable. It was done through the will of the legislature, for the record on that. And it's been a good transparency bill. Okay, so on that, as far as the other proposals, it's about reducing costs to the to the Mississippians about what they have to pay instead of give me more money. Yes, I understand about personally, I understand about the uncompensated care and where Mississippi is. And I don't envy the hospitals. I don't envy anybody like that. But the reality is, as presenters said today, the cost of healthcare keeps going up. Okay. And at least what I've heard from the managed care companies is that we're working on it. I don't ever hear that from the hospitals to say that. Okay. And what I have heard is that, you know what, we have 700, whatever it is, 250 beds. And you know what, we need money so we can cover the cost of 250 beds, even though we're treating 50 patients. And my numbers are exaggerating, but that's the point. So my point is, in your presentation, no, I did not see a solution-oriented way to approach the unreal costs that average Mississippians face every day. Your response to us has been, give us more money.
I can tell you that without your help, we have initiated quality improvement provisions through the Division of Medicaid that have reduced readmission rates with hospitals, that saves costs to the Medicaid program, and most importantly, saves patients. We've also developed an ACO, which has saved Medicare tens of millions of dollars just in the last couple of years. We've got, at the high point, we had almost 100,000 lives enrolled in that. That was not anything that we needed help with from the legislature to do. So that's probably why you didn't hear about it. There are numerous quality provisions that go on every day across the state of Mississippi in your hospital and in other hospitals that save patient lives and save payer dollars. Things that we don't need your help with, quite frankly. So if there are things that we need to talk about, we're certainly glad to do those, but those things happen every day. And again, when your costs are the lowest in the country, I would submit to you, cost is not a problem. Healthcare is expensive. I don't care where you are, it is expensive. Cell phones are expensive. Lots of things are expensive. But I would submit to you that our problem in Mississippi is not a problem born out of cost. It is a problem born out of revenue. And if we're interested in things that would enhance the state's revenue and also help hospitals, we can have a separate conversation about that as well. And I hope you'd be supportive of that.
Look, I respect and appreciate the representation that you bring for the hospital association, and I think that y'all do a good job on that. I do think that we see difference on this particular area. And I appreciate that y'all are doing those things that you just mentioned outside of the legislature because yeah, I mean, those things need to be done. You know, we can't solve every single thing. So I appreciate what y'all do and how you work on that. But I try to look for solutions, and you know, and that's and I know what I'm talking to, what I call the average Joe Mississippian, and they throw up their hands when it comes to hospitals and how they have to fund things and all of that stuff. And so, you know, it's I'm happy to continue the conversation at a different forum, just because I think we're running out of time. I do appreciate what y'all brought to the table, and I do think it is important that the things that y'all highlighted with the managed care organizations is important, because I personally have had those conversations with the MCOs, and I think that we're getting there to be better for the citizens of Mississippi. And it comes down to us all looking out for those folks, which I think y'all would agree on that.
Thank you.
Thank you, Mr. Chairman.
Thank you, Ms. Wiggins. Senator Bolt.
Please, for the record, note that I'm the only one left in the Senate on the committee, and call my wife and tell her how hard I'm working.
What am I, chopped liver?
Well, you're the chairman. You have to be here. Question, you mentioned earlier the pay scale of our medical professionals. Doesn't a lot of the hospital reimbursement depend on the federal government's guidelines for reimbursement, and they're setting that scale? And if so, is there any talk in DC of taking into consideration what has happened during COVID regarding medical professionals and any movement there to increase this reimbursement?
Yes, sir. There's a lot of talk about that. And one of the ways that the feds are talking about doing that is through what's called the wage index adjustment, where wages have gone up, and that applies through the Medicare payments. But when you look at this pie chart and you look at Medicare, those rates aren't negotiated by the hospitals. And really neither are, really any of the government payers. I mean, they're not, the hospitals and any other providers, they're not in a position to go sit down and negotiate what Medicare pays me. Those are all rates that are defined and dictated and pushed down. And so when you look at the Mississippi payer mix, really a little over 20% is about all that's really negotiable as far as what the rates go for hospitals. And when they're paid at or below cost by the overwhelming majority of those payer sources, it's really, really difficult for that other 20% to try to help offset some of those, again, low relative to the rest of the country, fixed cost. So when we talk about why we can't recruit physicians, why we can't recruit nurses, why don't we have this, why don't we have that? From a healthcare standpoint, a lot of it comes back to this pie chart and this payer mix where it's really difficult. I mean, it's math. It's not me making numbers up. Tim's not generating numbers. We're not sitting in some tower out in Madison just spooling up numbers to throw out here. These are the real numbers and real payer mix. And this is the real challenge that, and it's not just, I mean, this is a hospital snapshot, but other payers are getting paid pretty similarly to hospitals. I mean, this is the coverage group for physicians, for pharmacy, for labs. I mean, so this is what makes healthcare challenging in Mississippi, and our high poverty rates and our, high uninsured, all those are significant challenges. And we talked about, and Representative Director Snyder almost gave him a promotion or maybe a demotion, I'm not sure, said, we do the Medicaid managed care program on a cost plus basis. Well, hospitals and other healthcare providers, by and large, got paid cost plus years ago. It's not that way anymore. So we're not paying on a cost plus basis. There's no cost plus margin kind of baked in to the rates like 15, 20 years ago. And so when you're rate driven and your rates haven't really changed in a long time, it's just math. It makes it really hard.
Well, let's move forward from that. If you could increase salaries by an increase in funds, 30% to your non-doctors, medical professional non-doctors, is there a pool of workers that a 30% increase would fill all of our hospitals and nursing homes with the people they need?
Probably not. Probably not now.
So that leads me to this question. We have a little bit of money called ARPA funds. If we focus a lot of those funds on education of medical professionals, expanding the numbers that we can train, would that help solve the problems that you're facing?
Yes.
Even though we may not be able to raise the rate of pay that much?
Yes, sir. And, it's a long-term solution. And a few years ago, the legislature funded and IHL deployed a nurse forgivable loan program for nurse education. We don't do that anymore. That went away, I don't know how many years ago, but that put nurses in the pipeline and gave them forgivable loans so that once they completed their education, they went into the workforce, there was an incentive to do that. That program was eliminated several years ago. It doesn't exist. We could prop that back up. I mean, we're not talking about coming up with brand new ideas. We need to go back to some old ones that appeared to work to get people back in the pipeline. I mean, the immediate thing is you got to stop the bleed right now and try to do your best to hold on. But the long-term solution is getting more into the pipeline, whether that's through programs that the state can employ, or rather that's, increasing revenue, letting the private sector, the nurse, the hospital, the physicians all work together to determine how to do that.
So, Mr. Chairman, one thing to add to that is that the timeline that you're looking at there is a minimum 4 to 5 years. You want to get nurses in the program, get prereqs, and get them out. It's going to be close to 5, over 5 years, depending on when you catch it.
I was about to say, now that would, sounds like you're talking about a 4-year degree. It would take, community college is a 2-year program.
But they cannot function until it comes to work. And that's part of that's COVID. Part of that was replaced with COVID now, because they're not going to come into the clinical setting, that they want to do that. But that is deteriorating. We work at school nursing and nursing as well, trying to fix some of that. But it's, I was on a call just before all we get up, and it's across the board. It's not just nursing. We can allow things to progress and help them to be about, we got to think about it. Our expectations of that. And we've gotten the first one to say, no, hospital 30 years. We've got to change the model. And the expectation is the characteristics that we're putting out there, they've got to be different. But we're fully supportive of what you're talking about, increasing the education side. That is the long-term piece. And when we get it started, we can't stop. And we'll be right back where we are later.
And then, and another part of the challenge is when you look at the payers and the services that they rendered, I said earlier, you flipped from an inpatient heavy model of delivery to an outpatient heavy model of delivery. So no one's going to stand up, and despite what the chairman said, no one's asking to pay for 250 beds that aren't needed anymore. No one's asking for that. But you don't need that number of staff, and no one's expecting anyone to pay for that level of staff. But when you used to have staff to take care of maybe 100 people in a hospital one night, but now you only need a staff to take care of 50 people in a hospital, that's the free market. That the hospitals adjust to that world that they're presented with. So now knees and hips and joints, they're all done on an outpatient basis. You don't come in and spend 1, 2, 3 nights. So more procedures have moved to outpatient setting, which decreases the need for inpatient services. So you don't have floor nurses like you used to. They're now working in an ambulatory surgery center, or they're working somewhere else. And so that's, you know, that's part of the challenge too. It's just a natural free market progression. Well, now you flip the switch with COVID. Now it's like, well, hell, we need everybody back in the hospital. Well, you don't put all the, you know, the toothpaste back in the tube that quickly. So it's been that part of the progression as well. That's just an evolution of healthcare delivery.
Senator Blunt.
Thank you, Mr. Chairman. Just quickly, I know it's late. Senator Polk, I appreciate your question. I was going to ask the same question. I know and I appreciate you highlighting the nurse loan forgiveness program. None of those programs are being funded. We had a number of similar programs for teachers, same deal. They were not being funded. So this year we passed legislation I worked with Representative McCarty on, where we abolished all the teacher loan forgiveness programs, which were difficult to administer, not being funded, and often had default rates. We abolished them all, and we established a teacher loan repayment program to pay, essentially to help teachers pay down their college debt for going into the classroom, and the default rate on that is 0. So I think we ought to talk about looking at the nurse loan forgiveness programs. I think we can fund those, and there may be other things for other healthcare providers we can look at as part of that, and have a program that is like we did with teachers, that has no default rate, and then we got to fund it to going forward and address that. So there were comparable programs out there for teachers. We fixed it. Let's try to do the same thing for nurses.
And these are hard jobs.
Yeah.
I mean, these are not easy jobs, and it is hard work.
Right.
You know, if you're a floor nurse, you're taking care of critical patients, some of whom may not be in the best mood. It's a difficult job. So you've got to do what you can do to attract more people.
Just like teachers. Yes, sir.
Exactly.
Okay. Thank you.
Thanks.
I want to thank all the presenters. I think we had a spirited discussion. And Tim, just something you mentioned at the end, talking about, not staffing all these beds. When we had the COVID hit, there were people running around saying, we need to do away with the CON. We got to have hospitals on every corner. We got to have more beds. When those of us in the industry know we're moving more toward that outpatient, because it lowers cost. Just one more question. What's the average profit margin for the hospitals here in Mississippi?
Well, if you look at the latest full year of cost report data, which was 2019, the industry across the board, if you look at revenue coming in versus expenses going out, there were $11 million more in expenses than they had in revenue as an industry. So if you look at the industry across the whole, it's a negative margin. Individually, there's some obviously they're making a margin, but by and large, the industry as a whole in Mississippi was losing $11 million a month based on their cost reports.
Right. And then, so part of the criticisms I hear are on the opposite side. When you take a look at the insurance companies, be it managed care or whatever, and you take a look at their profits and what they're making versus what the providers are making, tremendous difference. In healthcare, I've been in it for 46 years. There's still things that pop up. I scratch my head, have to try to figure out. I'm sure you and Tim are the same way. It's a very complicated industry. It's very, very diverse. We have people who order tests or order procedures who have nothing to do with the paying for that. Then you have the provider who provides those services. Then you got another third party that's paying for those services, and they're going to determine if those services were actually needed.
Yeah.
So it's not just as easy as sitting down and saying, here's how we're going to operate. Hospitals contract with emergency room physicians. They're not employees, they're contracted. That's why you get a separate bill. And it happens in pathology and radiology and anesthesia for the primary services in a hospital. And the general public does not know that. But, I don't know how we go about educating the state on that, but it's been an interesting discussion. Appreciate you guys coming. Appreciate the members for attending. Senator Polk, I'll give you a gold star for sticking around.
Thank you.
Thank you.